call the meeting to order and rise for the pledge. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good evening, everybody. Please take the roll.
Director Wallace,
Present.
Director Stewart,
Present.
Director Epen,
Present.
Director Nicholson,
Present.
Director Danielson.
Thank you, Laura. Nancy?
Tonight is our budget presentation for the Board of Directors, and should the Board of Directors determine to pass the budget resolution this evening, it will constitute our spending authority for the coming fiscal year. Before I introduce the gentleman who will be making this presentation, I wanted to talk for just a minute about this budget. It provides for net operating revenue in the amount of $480,902,000. Now that the construction of the Morris Hyman Pavilion has reached completion, and on the 11th, we received the building on time, on budget. We will have to begin funding depreciation in this year. The day that we put patients in the building is the day that that depreciation expense begins. This year, the depreciation is budgeted at $41,134,000. I want to talk a little bit about that. We've had the opportunity to see many other hospitals come before us in the seismic retrofitting, seismic new construction process of becoming compliant with the state of California's laws. Many of the hospitals that have built new buildings like we have experienced exactly what I'm talking about, which is the additional expense of operating a new building, typically larger or additional to what is already there, and also the requirement to depreciate it hits their financial statements, and they find themselves in a state of financial reversal for several years after the opening of the building. As we worked our way through this budget, we have tried very hard to make sure that we finish with a positive bottom line and maintain all of our standards. It is going to require a level of vigilance operationally throughout the coming fiscal year that is unprecedented in the history of the hospital. It is going to be a real challenge, and there's no two ways about it. The other part of the environment that we're facing is absolute chaos and inaction in Washington. I mentioned in my letter of transmittal to the Board of Directors that the report from the trustees of the Medicare Trust Fund have been delivered to Congress just in the last week. And they have urged Congress to, quote, take action sooner rather than later so that it will permit consideration of a broader range of solutions and provide more time to phase in change so that the public has adequate time to prepare. And what they're talking about is the Medicare Hospital Fund being bankrupt in 8 years. That has to be incredibly sobering to anyone approaching their Medicare beneficiary years and any family with a senior citizen as a member in it. I'm not sure what Congress will do. They faced some really difficult issues this year and have done nothing. They keep kicking the can down the road. For a while, the target was 2030 for bankruptcy for Social Security and the Medicare Trust Fund. Now they're saying that utilization of hospital services is happening at an exponentially higher rate than they had projected. And that instead of the fund going bankrupt in 2030, they believe it will be bankrupt in 8 years. That is a stunning number. And in the lifetime that it takes Congress to take action, that's no time at all. So I think this is something we have to follow and pay very close attention to. I think it is one of the things that will disturb our public and our physicians and our hospital more than we can calculate. One of the other things I wanted to mention was that while we tried to take on any additional expense in this budget and to look for new sources of revenue, and there are those in this budget, there was one area where we increased our expense profile in a significant way. And that relates to an essential service our patients depend upon, specifically dialysis. For many years now, we've had a contract service here. They have proved themselves to be entirely unsatisfactory. Our physicians are very dissatisfied with the kind of service that is provided. We're upset over the lack of sophistication and training their practitioners are that they send here. We had a very disturbing incident that was reported to the state of California, appropriately so, and we were involved in that report. But the decision was made that we would no longer contract with this company for that service, and they will be leaving here in August. As a result, we will be increasing our expense profile by $865,000. That is the difference between what it will cost us to provide the service at a standard that is appropriate for good patient care, as opposed to what we were spending on them. Sometimes living by the patient-first ethic is difficult, especially in a year when we're facing extraordinary expenses hitting our financials like this year. But we have to put our money where our mouth is. And I believe the board should be aware of what we've done and will support us in doing this. Believe me, I did not feel there was any other recourse but to do this. We have tried very hard to make that contractual relationship work and have found it unsatisfactory. So this is what we will be doing in the coming fiscal year. And at the same time, there seems to be this litany of difficult news to deal with in this budget. There's one absolutely, unavoidably wonderful thing that's going to happen for our district and our patients and our employees and our doctors. And that is the opening of the Morris Hyman Pavilion, which is an extraordinary facility. All the more so because it came in on time, on budget. Very proud of Ed Fayen and his crew. They've done us proud. For a public works project to achieve that is unfortunately altogether too rare. So we are very proud of that, and we hope to be applying the same kind of rigor and discipline to our expenditures in the coming year so that we can come in on time, on budget next year when we're talking about our financial performance. With that, I'm going to invite our presenters to the podium. First, I'll begin by introducing Chris Henry, CPA. He's our Chief Financial Officer. He's well known to the board and I hope to the general public because he's a regular speaker at our board meetings, but I wanted to remind people of his credentials. He has a Bachelor of Science degree from California State University, East Bay, in business administration with an accounting emphasis. He worked in public accounting for 4 years after which he was certified as a certified public accountant. He joined Washington Hospital as the director of accounting in May of 2000, and in December of 2003, he was promoted to controller. Since October 2006, Chris has served as Washington Township Healthcare District's chief financial officer. In October of 2010, he took on the additional responsibilities of associate administrator. In December of 2016, he became a senior associate administrator. He's a member of the California Society of Certified Public Accountants, the American Institute of Certified Public Accountants, the California Hospital Association, and the Healthcare Financial Management Association. He serves on the board of directors, executive committee of the District Hospital Leadership Forum, and has served on the California Hospital Association's CFO Advisory Committee. Also presenting tonight is Daniel Nardoni. He is the Chief Financial Officer of Washington Township Medical Foundation. He also pinch hits in the finance department, as Chris is very capable assistant. He also graduated from California State University, East Bay, receiving his Bachelor of Science degree in Business Administration with an emphasis in accounting. In August 2013, he received his Master's of Business Administration and Healthcare Administration from the University of California, Irvine. He spent 3 years in a public accounting position with Arthur Anderson, working in their healthcare practice, followed by 5 years with Sutter Health as a senior accountant. In 2000, he joined Washington Hospital as a senior accountant. After 5 years in this position, Dan was promoted to budget manager. In 2009, he took on additional responsibilities as the director of budgeting and ancillary financial services, and in 2011 was made a senior director in the same role. Dan was promoted to assistant chief financial officer in October of 2015 and accepted the position of assistant CFO of the Washington Township Medical Foundation in October of 2017, and then was promoted in May this year to the chief financial officer for the Washington Township Medical Foundation. So with that, I'll hand the presentation over to Chris.
Well, thank you, Nancy. Before we get started, I want to make some acknowledgments. This was a rigorous budget process this year, and the budget you're going to see tonight is a culmination of work of every manager of every department in this hospital. This is not finance's budget. This is our budget. And I mean that wholeheartedly. Everybody has a piece in it in the management staff of Washington Hospital, and I want to thank them. I want to make some individual shout outs. First, I want to shout out to Brenda Brennan and Michael Platzbecker. Brenda's here, Michael's not here tonight. They are administrators in our emergency department. We kind of corralled Michael and Brenda into the process a couple of weeks ago and threw them directly into the deep end of the pool. And it's something that they have not been involved in before, and they rose to the occasion and made an absolute impact on this budget. So Brenda, thank you to you, and please extend that to Michael as well. We could not have achieved this without you two. I also want to acknowledge the associate administrators, Kimberly Hart, Ed Fayen, Stephanie Williams, and Tina Nunes. They likewise have spent a lot of hours and effort in producing this budget. And they do this every year without complaining and without any thought, and I really appreciate it. Again, we couldn't do this without you. I want to acknowledge Erica Nelson. She is our Director of Financial Planning and Analysis. This was her first year getting into the depths of this budget, and she got into the minute detail, and like Brenda and Michael, was thrown directly into the deep end of the pool. And Erica, you rose up to the occasion, and I thank you very much for your hard work and effort and sacrifice. Finally, my partner in crime, Dan Nardoni. Dan, this is our 12th or our 13th budget together directly on it, and we've worked on it indirectly together for the better part of 18 years. So, Dan has always been there keeping this thing moving forward and keeping us all organized and getting this done on time. So, Dan, thank you so much for your help. So, as Nancy mentioned, from an environment standpoint, things really haven't changed a lot. At the national level, state level, and the local level, although there's been some, we'll talk about it in a few minutes, there's been some really good change actually at the district level. But it's the environment that really has become the norm rather than the exception. Since the passage of the ACA, the Affordable Care Act, the gridlock in Washington has been paralyzing. And 10 years ago we were saying this is the exception, but now it seems to become the norm. And our mission statement doesn't change regardless of those conditions, and we have to adapt and learn how to achieve our mission in that environment, and I think we've done so pretty well over the years. And I just want to remind people about that mission statement. It doesn't matter what the environment is. We're here to achieve it. This budget is the financial embodiment of that mission and allows us to move forward. So let's get to the national environment. As Nancy mentioned, paralysis continues in Washington. When we were talking about this last year, the Republicans they thought on their way to repealing and replacing the Affordable Care Act with their own version of health care reform, but despite having a supermajority in Washington, were unable to do so. So they've tabled further work on that until after the midterm elections, but in reality, if the Democrats manage to gain many seats or gain control of one of the houses, the ability to do that is unlikely. But they have been chipping away at some of the rules and other things embodied in the Affordable Care Act. One of the things they did get done was the repeal of the penalty related to the individual mandate. And the individual mandate basically required every American to have health insurance. In reality, the $695 penalty was hardly a deterrent to not having an insurance policy because it cost them a heck of a lot more to buy that on the exchanges. So they managed to do away with that. And then just this week, Attorney General Jeff Sessions has announced that the Justice Department will not defend a lawsuit in Texas attacking the individual mandate as unconstitutional. So it is likely that the individual mandate will go away. Likewise, the Republicans are really pushing the concept of expanding the availability of association health plans. Now, what an association health plan is it is a consortium of small business people who can collectively go and negotiate directly with healthcare insurers. Right now, their only option is to buy insurance on the exchange or to buy exorbitantly expensive insurance privately. It's really focused on the health insurance exchanges because with large expansion of these associations and the ability of small employers to negotiate as a group with the insurance companies, they're really not going to need to buy their insurances on the exchanges. So it could very well hurt or cripple many of the exchanges in the country. So this is how the Republicans are kind of going about working around the Affordable Care Act and trying to tear it down piece by piece. There are other federal initiatives going on around healthcare. One of them is there's legislation to redefine the 340B pharmacy program. And what the 340B pharmacy program is it allows healthcare providers to purchase drugs from manufacturers at a discounted price for the purpose of treating the medically indigent. It's a recognition that there is a high cost to treating the medically indigent when there's no reimbursement, and it really allows a lot of providers to provide more service to that population. But it has been the original law, frankly, was poorly written. It was very vague, and there have been organizations that have taken advantage of that and really used it for purposes that it was not initially intended for. So they want to redefine it, and part of that redefinition, of course, is a cut in payment. For us, that cut in payment, I think we've estimated that to be at about $500,000 if it goes through as it's projected right now. But that's ongoing. The House Committee on Energy and Commerce is currently conducting a probe into CMS's accreditation process. There's a feeling that perhaps CMS's accreditation process isn't rigorous enough, and this is the process that's used to validate us and validate our license with Medicare as a healthcare provider. And so they're particularly looking into the oversight, CMS's oversight of the organizations that perform that service for them, going out and do the accreditation, such as the Joint Commission. It's kind of changed the tone of our accreditation surveys. We had 6 surveys this last year, and I'll talk about those in a little while. But we had 6 surveys this year, and the tone of those surveys have taken a decided move from a collaborative process to a much more punitive process. So the accreditation bodies are feeling the heat. It's a big change in how that works. There are also multiple legislation initiatives around the opioid crisis at the federal level. It's a hot topic, and they're considering a number of things, including limits on initial prescription amounts for opioids. They're looking at grants to support prevention, treatment, and recovery efforts. They'd like to fund education programs for providers and patients regarding pain management and substance abuse. And there's greater greater support of state-to-state monitoring programs around drug use. So, still things going on around healthcare in Washington, but not the kind of volume that we've seen in the past. In California, California's economy remains strong and is expected to continue that way into the foreseeable future. The government's proposed budget contained a few provisions that impacted healthcare. The biggest one was where the federal government is looking at restructuring the 340B program. The state was looking at doing away with it altogether. There are a number of reasons for that. They feel that the administrative burden is high, and there's really not a whole lot in it for the state of California. They feel that there's general fund savings in doing away with this, but they haven't yet been able to quantify it. And any savings they get to the general fund by eliminating 340B and Medi-Cal will be on the backs of providers. So it's a tough issue. There are a lot of hospitals, particularly in the Central Valley, that depend on that funding in areas like Tulare County, where, here we have about a 20% Medi-Cal in our gross revenue mix. Tulare County, it's 55%. So it's significant to a lot of rural hospitals in the state. We'll see what happens with that. I believe that piece has been pulled out of the governor's budget at this point. There are also several mental health initiatives included in the governor's budget. There's money for housing for the homeless. There's been a direct correlation made between housing status and health status. So these are good things. Mental health services in the state and in the country, and particularly here in the district, are really lacking. So it's good to see these things. They're considering restoring $254 million to counties for treatment of seriously emotionally disturbed youth. There's very few services available to adults. There are even fewer services available to youth. So this would be a great thing. They're providing money for outreach to homeless people with mental illness in the counties. That's another great thing. And there's $55 million in there for psychiatry graduate medical education programs. There's a huge shortage of psychiatrists in the state and nationally. Now, I will note that they also provided money for this last year, and they granted it to UCSF to administer the program, and then the governor cut UC's budget in the same amount. So we'll see what happens this year. Hopefully that shenanigan won't go on. I think it was 2004, Prop 63 was passed, which was a 1% tax on the wealthiest individuals in the state to provide money for psych. Last year, 90% of that money went to the prison system. So it's not trickling down to the people that need it out here on the streets and in our communities. So hopefully that trend will change this year with these initiatives. Other state healthcare initiatives that are bouncing around, a single payer system is still floating around in Sacramento. I think they're trying to figure out how to fund the $400 billion that it's expected to cost, but they haven't let go of that. Also, there's an initiative kind of rolling on reimbursement rates and limiting the reimbursement rates to healthcare providers. We'll see. All of this is in the light of this reality that we talk about every year. Nobody likes to talk about this, so I kind of do like to talk about it because it's really the situation. So for fiscal 18, we've projected that the total unrecovered cost, and this is cost, not charges, total unrecovered cost from government programs here at Washington Hospital will be $129,840,000. That's not small change. We're expecting that Medicare will cover about 58.5% of the cost of providing services to their beneficiaries. Medi-Cal is even worse at 46.8%. It's tough. And the reality of what happens here is that we got to get this money somewhere. If we had to absorb that cost, we'd close our doors. So what happens is this unrecovered cost gets shifted to the insurance companies, to private insurance companies when we negotiate our rates with them. So they don't like that, of course, but it's the reality of keeping this place open. And what they do is they can't absorb that cost either, so they shift it on to the ratepayers, which are our business people and the individuals who are paying for insurance. It is a hidden tax that really nobody wants to talk about. So it's unfortunate, but it's the truth. And this is all in this environment where the Medicare Trust Fund, as Nancy said, is facing insolvency in 8 years. And in the same environment, this is also our reality. We have had a number of unfunded mandates and payment reductions that started back in 2009, 2010, when the Affordable Care Act began. One of the unfunded mandates, the biggest one, and part of what this building, the new building, is about is a response to this, is California seismic requirements. To date, we've spent over $543 million on those initiatives. The requirement for the electronic health record that came in several years ago, that's when we installed Epic. So far, cumulatively, we've spent $92.1 million on that requirement. California CMS payment reductions that started back in 2010, cumulatively now up to $97,212,000. When several years ago, when the federal government was having trouble getting a budget, they implemented sequestration rules. Part of those sequestration rules included a 2% cut to Medicare payments. They have since repealed those sequestration cuts, with the exception of the Medicare cut of 2% in payments. So that one persists. Government licenses, fees, and other mandated costs so far have cost us $28.8 million. Incidentally, the fees related to just building that building out there are over $4 million. So an estimated total impact of over $750 million over the last 9 or 10 years that we've had to cover in our budgets and keep this place going. But it's not all bad news. So let's talk about the district, because there's good news here too. So we always look to the East Bay Economic Development Alliance forecasts for the East Bay when we get to this part. They are a group that focuses on economic developments in the East Bay. They work with Beacon Economics to provide an annual report and projections. So their report that just came out in April has projected job growth rate in the East Bay at 1.7%, and they expect that rate to continue through the end of the calendar year. And that's better than the national rate of 1.5%, so the East Bay continues to be strong. They also say they expect unemployment will remain below 4% for the foreseeable future. Unemployment in the East Bay overall has improved from 1.1% at this time 4.1% at this time last year to 3% as of March. And again, this is well below the state average of 4.3%. In the district has always done better than the East Bay overall. The unemployment rate's down to 2.4%, and that's down from the peak of 9.7% in 2009. So the district residents are really doing a lot better than they were at the apex of the 07, 08, 09 crash. But as unemployment has fallen, this is new, in the labor force, and growth in the labor force in the East Bay has slowed and only added 200 individuals last year in the labor force. So I think that may be a reflection of the cost of living in the East Bay, the lack of housing, the lack of affordable housing in the East Bay. So anybody who's tried to hire in this environment recently knows that people are scarce as hen's teeth, and competition for good quality talent is fierce. Overall, Beacon says the key economic indicators are positive, and the gains are expected to persist in the long run. So it's an upbeat report from the East Bay Economic Development Alliance. Also, here at Washington Hospital, during all this, we've had some terrific successes. I mentioned a little bit earlier about our surveys. This was the year of surveys. We had 6 major surveys, 3 from CMS, 1 by CDPH, and 3 by the Joint Commission. They surveyed the hospital overall. They surveyed our laboratory program. They surveyed our stroke program. These are unannounced surveys. They typically are here for a period of 3 to 5 days. They come with a team and they turn this place upside down. These are the surveys that have generated the headlines recently of big fines on hospitals, hospitals having their licenses threatened, etc. But I'm pleased to announce that through this 6 months of surveys that we endured, we had no fines and no follow-up items after any one of these surveys. So it was very successful for us and is really indicative of the level of attention that's being paid by our staff on regulation and quality here at Washington Hospital. Some other accomplishments this year: Health Grades, which is one of the major organizations that rates healthcare providers, named us, gave us a really huge honor in naming us one of America's top 100 hospitals. And it's just huge for us. We also were named top 100 best hospitals for orthopedic surgery and joint replacement. That places us in the top 10% of the nation for for orthopedic and a top 5% for joint replacement. We also received for the 5th consecutive year the prestigious Distinguished Hospital for Clinical Excellence Award. So those are really huge honors, and we're really pleased to get them. We received another of other awards from Health Grades. For the 5th consecutive year, we received the Orthopedic Surgery Excellence Award. For the 12th consecutive year, we received the Joint Replacement Excellence Award. 5-star ratings for hip replacement, treatment of heart attack, treatment of sepsis, and treatment of pneumonia, all multiple year recipients in all those programs. So some great quality going on here at Washington, and a staff that really takes this stuff seriously. Other recognitions this year, we received 2 Quest for Zero quality awards from Beta Healthcare related to the work being done in our emergency department and in OB. We received recognition from Practice Green Health as a partner for change. That's related to our work on being a greener organization, and we received the Best of Fremont Award here locally. So a great year for recognitions. And now let's talk about this, the Morris Hyman Critical Care Pavilion. Culmination of several decades of planning. Nancy talks about coming into a meeting when she first got here and seeing a site plan, and I wish I had a picture of this, with a red box in the middle of the site. And it was called the Red Building. That had to have been 25, 30 years ago. And here it is, the Red Building. We were, as Ed mentioned, or Nancy mentioned, we were handed the keys to the building for stock and staff on Monday. And with the good graces of the state licensure, we will be opening it in mid-October. So let's take a look at some of the statistics. 240 total square feet, of which 177,800 are built out and 47,000 square feet shelled in for future uses. The system, the building's built on a base isolation system, which is essentially 72 platters that the building can move on in the case of an earthquake. It's designed to survive a magnitude 7.9 tremor. Brand new, badly needed 25,000 plus square foot emergency room. I think when the ED staff move in there, they're going to get lost. They're used to being elbow to elbow in our current emergency room. And the real big change here is not just the square footage, it's the fact that we're going to have 39 private rooms. No more curtains. They're going to be rooms with walls and doors. Really a great thing for our patients to have some more privacy in there. It includes 68 private med-surg patient rooms. All of these have exposure to natural lighting. And again, nice and spacious, accommodations for families to sleep overnight if they need to or want to. 48 intensive care critical bed or critical care bedrooms. Again, private rooms, natural lighting, and accommodations for families. 2 outdoor terraces that are accessible to patients and families, and several more outdoor terraces that aren't accessible but are outside the rooms and really are beautiful. And I mentioned that all of our critical care and med-surg rooms will have accommodations for families. So let's look at the cost of all this. So the first thing we're going to look at is the move, and this covers the period from July 1 to opening date. And right now that's projected, as I said, to be mid-October. It all depends on licensure. Licensure has been running behind, we hear, but we're taking great lengths to keep them up to date on what we're doing. Ed and his crew have been meeting with them and will continue to have meetings through this period so that we can do everything we can to make sure we get this building licensed on time to open mid-October. So the move, these are the one-time expenses related just to that period before we open. Logistics and planning, occupancy planning, about $371,000. This includes the moving company. It includes planning for the move, those sorts of activities. We've got consultants and other external support. This includes the company Calliston TKL, who has been helping us plan for this whole thing and will help us get this thing moved and putting all the logistics together. It includes Doug Van Houten, who was kind enough to come out of retirement to help lead us through this. There's also got some money in there for Rona Consulting. We plan to do, I believe it's 7 Kaizen events over the next several months, looking at workflows in the new building. We're going to have to learn to work in this place before we move in there. And because of the differences in the space, we really need to look at workflows to make sure that they're optimized for the new environment. We've got some money in there for department activation, and this is really getting down to the details in the departments to make sure we've got checklists for everything that needs to be in the rooms, everything that needs to be stocked in the departments, so that we don't get in there and go to reach for something and not have it. The largest expense in this category is training. We are going to be training hundreds of employees, including, and the level of training will depend on where they work and what they do. There's going to be a minimum 2-hour walkthrough through the building to orient people through the building, so they understand where the emergency exits are, so they understand where the elevators are, just basic understanding of the building. There are also departmental training activities that can range from 8 to 12 hours, depending on which department it is. With the workflow changes and just the physical changes and where things are, we're really going to spend time making sure that when employees walk in on the first day and are ready to work, they know where everything is. New facilities operations, this is just the cost of running the building during that period. Includes engineering, utilities, all that sort of thing. Operational process redesign, again, those are those Kaizen events I mentioned. Communications and events, we're gonna, we gotta get the word out, and we'll have a ribbon cutting and that sort of thing, and that's the cost of that. And then deactivation of existing units. We're going to be moving whole departments out of the old hospital building into the new one, and we want to go back and secure those areas that we vacated. So this includes putting in lockable doors, building some walls, really shutting those areas down until we decide what future use we'll put them to. So in total, the one-time costs are a little bit under $2.4 million. Those costs will appear below the operating bottom line in non-operating expense, as a non-operating expense. Been some discussions with our auditors, and auditors and accountants like to put different names to things. I call this is an extraordinary event, right? We do this once every 50 years. They like to call it an unusual event, so okay, whatever. It's going to go into non-operating, this piece of it. Now let's look at the ongoing operational assumptions for the building, and these are incremental changes. These are not the total cost of what's going on in the organization. The way we approached this budget was to budget as normal, and then think about what are the incremental costs going to be in moving into that building. So we're estimating for the period we'll be open next year, an increase in FTEs of about 18.6. That includes some nurses and some techs in the clinical area. Additional plant maintenance, of course. We're going to need a couple of engineers and some extra folks to do work in the grounds. Housekeeping is a big one. There's a couple thousand square feet additional that we're going to have to keep clean, and so big increase there. And then support services in areas like materials management, purchasing, and some other places. So total of 18.6 incremental increase in FTEs. Additional volume. Emergency, we really base the incremental change of volume related to this building on emergency room visits. We've been told by numerous sources to expect anywhere from a 10% to a 40% increase in emergency room visits when we open this building. We chose to err on the conservative side of that equation at 10%, and we didn't budget 10% on day one. We ramped it up in October, November, and December to reach a peak of 10% in January. Will it happen? Everybody guarantees us it will. We'll see. So all these other statistics are driven off of that. Those emergency room visits, we expect to generate an additional 583 admissions, some 3,500 patient days, 82 more surgical cases, and 102 cath lab procedures. So those are embodied in these numbers. So let's take a look at the financials on this. As I mentioned, the move column will flow down to non-operating. Salaries and wages expected to go up about, and what wasn't included in those FTEs I showed you earlier was a change for volume. Those were just people, okay? So these salaries include those changes in volume. So salaries increase of about 6.8 million there. And the related benefits about $562,000, increase in supplies of about $530,000, and I forgot to mention net revenue up above of about 17 million. Purchase services expected to increase about 405,000. Utilities 699,000, 700,000 in total once we turn on the lights. Insurance increasing a little over 200,000. Software licenses and maintenance about 66,000. Other expenses 250,000. Depreciation. I want to talk about depreciation, and I want to talk about bad debt. What you're probably missing here is you don't see the provision for bad debt and charity. There have been some changes in GASB over the years on where things are classified. So starting next year, we're going to be making those changes to become in more conformance with a true GASB presentation. So what happens is provision for bad debt and charity actually moves up into net revenue where it logically belongs anyway. But under GASB, interest expense really becomes non-operating. So we'll be moving that down into non-operating to be in conformance with that presentation. I also want to mention that depreciation, I want to mention the nature of depreciation. So and I'll try to be brief here. So there's a principle in accounting called the matching principle. And what the matching principle says is you want to match income earned with the expenses incurred. It's that simple, regardless of timing. What depreciation is the recognition over time of a big expenditure that's made on a long-lived asset. So we're spending $350 some odd million on this building. We're going to recognize that expense over 40 years, basically. So the increase in depreciation is the recognition of that expense. It is not an impact on cash flow. It is the recognition of cash flow that has occurred in the past. So I hope everybody understands that. If not, please call me and I'll explain it to you further. As far as the interest expense goes, and by the way, this number will start when we turn on the lights and we start operating in there. Interest expense, likewise, is not a change in cash flow, it's a change in the accounting of where it goes. While we're building the building, this interest gets included as part of the cost of the building. Once we turn on the lights, it becomes an income statement expense and shows up on the bottom line. Again, this cash flow is already occurring. It's just an accounting change. So I just wanted to be clear about those two items because they're big and they do stand out. So as far as ongoing operations, we expect the ongoing operations piece to impact our operating bottom line with a reduction of that of about 2.3 million. When you bring in the interest expense, a total reduction on the bottom line of about 13.6 million. You combine that with the one-time expenses that are going to show up in non-operating, so an impact on our bottom line this year of almost $16 million. Any questions on that? Okay. So let's get into the overall budget. So the fiscal year 19 budget provides for, as Nancy mentioned, $480.9 million in total revenue, the funding of total depreciation expense of $41.1 million, contributions to our retirement plan and our post-retirement benefit plans of $25.1 million. It provides for the priorities of the strategic map that the board approved in 2016. It provides revenue bond debt service and the related tax revenue of $17.5 million. 17.2 million. Provides for revenue bond service, debt service of $17.5 million. Net income targets are a operating bottom line of $17.7 million. Total net income for the hospital of $19.8 million. It keeps us in compliance with all of our debt requirements, debt service coverage of 3.7 to 1, and it provides for new capital spending requests of $8.7 million. You know, I gotta say one more thing before I turn this over to Dan. This budget, and particularly with the building, is our best guess at what we think is going to happen. And I have to tell you, I got to reach out to Nancy, and I didn't do this earlier, but Nancy's guidance through this has been crucial. And her vision and her work with us on this budget really has been crucial. This building that we're bringing on, she has really brought to life, and we've done it. I think she'd be the first one to say we've done it as a team, but this is really, her drive and her vision, and Nancy, thank you for everything you've done here. It's been a monumental task, and your support and your vision and your guidance has been critical in developing these numbers and forging our path into the future.
We did it as a team.
So with that, I'm going to hand things over to Dan Nardoni to walk you through the details of the numbers.
All right. Good evening. Just wanted to start off thanking Chris and Nancy for their leadership and this opportunity as well. And the opportunity to present to you the financial number figures as well as the statistics that back this budget up. As Chris has mentioned and Nancy mentioned, this has been one of a particularly challenging year for us with the variables related to the move that Chris just went over and that transition to the Morris Hyman Pavilion. I really have to thank the executive staff for all of their hard work and support, along with our financial team. All right, so now that they've stole my thunder with the income statement, let's go back over it one more time real quick. So this budget provides for $480.9 million of net operating revenue, a 7.4% increase in operating expenses, operating income at $17.7 million, and hospital net income of $19.8 million. It also provides for the funding of the Development Corporation and its related entities in the amount of $19.1 million. This bringing us to a thin consolidated net income of about $681,000. And behind every good budget is the volume that creates that net revenue. So let's get into the numbers here. Admissions are anticipated to increase to 13,230, about 5.4%. The majority of this increase is due to the anticipated growth in volume from the opening of the Morris Hyman Critical Care Pavilion and the additional volume expected through the emergency room. In addition to those increases, we also expect an increase in neurosurgeries, joint replacement surgeries, and cardiac surgeries, along with an additional amounts for non-vascular interventional radiology cases. Patient days of 63,145 are anticipated to increase by about 6.5%, giving us an average daily census of 173. Again, this due to the volumes that we just mentioned. Outpatient observation days of 1,601 are expected to increase about 4%, and again, this is anticipated as an increase coming through the emergency room. As you know, patients having come through our ED are treated in a dedicated ED observation unit by hospitalists who specialize in this area. This has led to reductions in the length of stay for our observation patients over the last 18 months, and this has been reflected in this budget. Average length of stay is expected to increase 1.9% to 4.77. This increase really relating to additional neurosurgery and cardiac surgery cases, as those cases tend to have longer lengths of stay. Deliveries are increasing to 1,756, about 5%. This relates to a full year of operation of the prenatal diagnostic clinic, along with the addition of an OB to our provider, an OB provider in our medical foundation. With the enhanced coordination of care provided by the prenatal diagnostic clinic, along with our OBGYNs and the special care nursery, some of the high-risk mothers and their babies who historically have had to leave the district to have their children are now being born and cared for at Washington Hospital. So this is a great accomplishment. Surgical cases are going up 3.8% to 4,436. This includes joint replacement cases that are increasing by 80, and that's a mixture of inpatient and outpatient cases now. Neurosurgical cases are increasing by 10.7% to 330 with the continued growth in this program. And cardiac surgical cases are expected to increase to 126 as our relationship with UCSF providing cardiac surgical services continues. General surgery cases are increasing to 2,250, and again due to anticipated increases coming through the emergency department. Cath lab procedures are expected to increase to 4,049, about 3.6%. We anticipate a slight increase in cardiac procedures to 1,715 related to this expansion in the ED, and we're also expecting an increase of about 3.1% in our peripheral vascular procedures. Neurointerventional radiology procedures are expected to remain consistent with the current year, and our non-vascular interventional radiology procedures are expected to increase about 7.3% as we're following the trend of these types of procedures as they continue to grow. Emergency room volume, as Chris has pointed out, going up to 55,803, about 6.2%. And then our non-emergency outpatient visits at 87,666, again reflect a full year of operation of the prenatal diagnostic clinic, along with a little bit of growth in our infusion center as the oncology program continues to grow. Now looking at our performance indicators, we're expecting total paid FTEs to be about 1,522.3, an increase of about 6%. Most of this increase is related to volume and the positions needed for the transition to the Morris Hyman Critical Care Pavilion. Additionally, there are FTEs related to new and developing programs, which include the transition to the dialysis dialysis services back to Washington Hospital employees that Nancy had mentioned earlier. In addition to that, we also have a social worker that will now be part of the Fremont Police Department. And Nancy, did you want to mention a little something about that program?
One of the things that happened this year was that the City of Fremont's Police Department had entered into an agreement this past year with the county. The county was to provide skilled mental health workers to go out with the PD. So they got all of their people in the PD trained to do this. And at the last minute, the county backed out. Our emergency room is profoundly impacted by the mentally ill. And I felt very strongly that it was in our best interest to help the PD. And so we are recruiting for an individual who will be our employee, but be assigned to the PD. And hopefully this will help downstream in the emergency room. We'll perhaps have some advance warning of patients that are coming to our emergency room that are either dangerous or of a particular concern. We've had an awful lot of people that work for us injured by mentally ill patients over the course of the last year, both on the floors and in our emergency room. And I think we have to do some things to protect our employees. And I felt very strongly that this was an affirmative step in that direction. It is something that I plan to take up with our supervisors. I was very disturbed to hear that the county didn't follow through with the promised FTEs to assist the police department. The police department are not trained mental health professionals, and yet they are the front line in our community. And just like our employees take a terrible beating in the emergency room, so do the police officers. It's a dangerous situation, and to introduce mental health professionals who are trained to deal with patients with these problems, I think, is critical to public safety and to the safety of our police officers and our employees. So that's why I did it. I didn't want all that training to go to waste. I felt this could help us.
Okay, thank you. All right, so let's take a look at some of our graphs. We'll start with admissions. As you can see, the admissions trending up to 13,230 for fiscal year 19. Related to all the volume we've been talking about through the emergency department and those neuro, cardiac, and joint replacement surgeries. Admissions by pair, as you can see the increase in admissions, we aren't really expecting a whole lot of change in our pair mix this year. So that remains pretty constant, but as you can see, this graph really points out the high percentage that Medicare makes up of our total payer mix. Inpatient days are increasing to 63,145. But what you can also see in this graph is a reduction from 2017 to 2018. And I think this is a direct reflection of the 2018, we'll call it flu season. It wasn't nearly as severe as what we experienced in 2017. And deliveries going up 5% to 1,756. Again, related to that full year of the prenatal diagnostic clinic and an additional OB in our medical foundation. Total surgeries increasing to 4,436. And one of the things I noticed when I put this slide together was the fact that between the actual amounts for 2017 and 2018, we had a dip there. And some anecdotal information I had heard about was that this had been really going on in a lot of the hospitals in the Bay Area. And we may think that this is really related to that transition of a lot of our outpatient surgeries into the ambulatory surgery centers that's been going on.
Real push from payers. And the feds alike to get as much out of the inpatient setting as they possibly can.
Our emergency room visits going up to 55,803. And again, you can see again that change from 2017 to 2018, pointing out that change in the severity of that flu season that we experienced. Outpatient visits going up to 87,666. Again, a full year of the prenatal diagnostic clinic and continued growth in our infusion center and the oncology program. So let's get into the financials a little bit here. So patient service revenue going up about 8.6% to $2.178 billion. This increase driven by the additional volume that we've been talking about, as well as a market-based price increase of 3% that we intend to implement midway through the year. This is the first price increase we've done in 5 years. As you know, the cost of resources in healthcare continue to rise, especially labor and pharmaceutical costs. They've risen over the last 5 years to the point that make this increase necessary. Contractual allowances are estimated at 76.3% of revenue. This is slightly increased from 75.5% as expected, due in most part to the market-based price increase that we'll implement. As you're aware and has been spoken about by Chris, Medicare and Medi-Cal, even though we increase our prices, does not pay us any more for those services. So that cost shifting that Chris talked about occurs, and that cost ends up shifting to the consumer, and eventually through the increase in premiums. Provision for charity and doubtful accounts, increasing about $3 million. That related to the additions of gross revenue. Currently, we're at about 2.1% of gross revenue with our provision for charity and doubtful accounts. This is one of those areas that over the last year we were talking about it when we had this budget presentation, that we thought it might be an area that would start creeping up. And sure enough, we've gone from about 1.8% to up almost 2.1% at this point. The problem with this in the budget is trying to predict what that next step might be. So we've decided to stay with what we know at 2.1% for now. Including the provision for charity and doubtful accounts, the net patient revenue is targeted at about $471.6 million. Looking at our other operating revenue, we're expecting other operating revenue to decrease by about $8.2 million, although the cafeteria revenue is expected to increase by 147.4%. This, with the greatly anticipated reopening of our cafeteria next week. Yes, I think we'll be very happy. We'll be very happy to see those food trucks go away. Happy for our stomachs and happy for our wallets. This is also being offset by our decreases in our projection for the Prime Project Fund. As you may recall, Washington Hospital is participating in the Public Hospital Redesign and Incentives in Medi-Cal program, Prime, which is part of the Medi-Cal 2020 waiver. For Washington Hospital, our projects in this include the prenatal diagnostic clinic and the palliative care program. Prime provides startup funds and performance-based funding for these programs over a 5-year period. In July, we'll be starting year 3 of that program. This decline you see in revenue here is really a timing difference between the recognition of our performance in the prior year to what we recognized in 2018. In 2019, we don't expect that same timing difference to occur. Other revenue is made up of donations, interest income, insurance company rebates and refunds, WeConnect fees, and pharmacy resident stipends, amongst other small items. As you recall, in January, Washington Hospital Healthcare Foundation donated over $4 million to the hospital from the past capital campaign that had taken place. We anticipate this will be a little less in 2019 as pledge payments will be received over the next few years relating to our new campaign. Let's look at our operating expenses. As I mentioned earlier, the base for our operating expenses budget is accomplished by zero basing the majority of our operating expenses. We require our managers to justify the resources they need for the new year. We don't just give them what they spent last year plus a percentage. We go back and we actually make them dig in and tell us about what they need. With that, salaries are coming in at 7.2%, or $14.1 million higher than the projected. In addition to the increases for volume, new programs, and other positions needed for the transition to the Morrisheim Pavilion, this also includes wage inflation of between 1.5% and 4% based on current contracts. Benefits are increasing about $2.5 million. This includes about 10% inflation for health and welfare benefits, along with increases in payroll taxes related to the salaries and wages. Our professional fees are increasing about 0.7%, and this is primarily due to growth in our oncology program and a full year of the prenatal diagnostic clinic affiliation with UCSF. Supplies are increasing 6.5%, or $3.5 million. This includes an increase for volume, as well as 3% inflation for medical supplies and 8% inflation for pharmaceuticals. This is offset in some regard by our anticipated savings through the group purchasing organization. You know, year after year, pharmacy inflation outpaces general medical supplies by almost 2 to 1. And this brought, when we put this together, this brought to mind our latest saline shortage that we incurred. And the increase in our IV cost over this last year were $400,000 due to this. Purchase services are expected to increase by 2.2%. A lot of this due to the increased security for the new building. Annual district board election is coming up this year, our 60th anniversary, and some increases in hardware maintenance as we bring on new equipment. Utilities are expected to increase by 19.2%. This is due in large part to the opening and transition to the Morris Hyman Critical Care Pavilion, as well as 3% inflation on electricity. Insurance is decreasing by $709,000. This increase reflects the increase in volume that we've been talking about as it affects our professional liability insurance, along with a 5% increase in our property insurance premiums, and additionally, the property insurance related to the Morris Hyman Pavilion. Marketing expenses are going up 38.3% or $651,000. This increase represents a full year of our partnership with KGO and the Bay Area Healthier Together program as we expand our outreach to the region. Software license and maintenance expenses are going up $509,000. You know, this line continues to do nothing but climb as we become more and more dependent on our software and IT services. One of the large items in this driving this increase this year is the new Cisco telephone system that's come online. And other expenses. Other expenses include taxes and licenses, building and equipment rentals, postage, freight, and other miscellaneous items. One of the major increases this year, accounting for the 4.3% increase, is the operating leases for the striker towers needed in our OR. You know, a lot of times with this new technology changing at such a rapid pace, it makes more sense to lease this equipment than to actually go ahead and buy it. So that's what we're doing with these striker towers. Additionally, we're expecting a 24.3% increase in depreciation, as Chris had mentioned, due in majority to the Morris Hyman Pavilion, and then also the new projects and equipment that we're anticipating for the new year. And here's a look at our operating expense distribution. Again, as usual, labor cost leading our cost profile at 62%, followed by professional fees and purchase services at 13%, as well as supplies at 13%, depreciation at 9%, and other at 3%. Looking at our non-operating income and expenses, expected to decrease by $8.2 million this year. Investment income is expected to increase as a result of the increase in cash flow from operations, and property tax revenue increasing 5.7%. This really fluctuates based on the actual amount collected by the county, and this revenue is collected to pay for the debt service on our general obligation bonds. Interest expense is going up 159.5% to $18.4 million, and as Chris had talked about, that's really the function of us having to bring all that interest expense and debt service that we've actually been paying on all along into our income statement with the building going live. We are expecting an increase in net rental income, about 9%, related to the rental income for the Fremont office centers and the Washington properties. Amortization of intangible assets, kind of a funny line. It's really a non-cash accounting entry required by the accounting standards and relates to the acquired leases as part of the Fremont Office Center. As you can see, that's decreasing this year to $1.6 million, which is a good thing. And the non-recurring item that we have on here for $2.379 million is the move budget that Chris has showed you previously. As you know, we don't budget for realized and unrealized gains and losses, as it's hard to predict what the market will do. And then what I've got here now is a list of our capital project requests. These are projects that we anticipate will be coming to you for approval during this next fiscal year. For facility projects, that main project being the pre-op testing renovation, the ACER CT radiation dose reduction. And again, it's time to upgrade Epic, of course. And so our 2018 Epic upgrade leads the list of our IT projects that are coming online. Additionally, we have equipment that will be coming to you for approval, including phase 2 of our defibrillator replacements, the Alaris Infusion PCU infusion pump brains. So what is that? But it's actually the brain that actually operates the entire pump. So those will be coming this year. These bring in our total projects to about $4.9 million and our total equipment about $3.5 million for a total capital request for fiscal 19 of about $8.375 million. And again, at the bottom here, we show you the spending that's going to continue on our previously approved projects. For facilities, that's about $800,000, and for IT, almost $2.1 million. And that concludes our presentation of the FY19 budget. Thank you for your patience, and are there any questions?
Thank you, Chris and Dan. Thank you. Any questions? Anybody else?
That's remarkable work.
Yeah. I'm trying to think back 28 years ago when I first became a board member. These numbers astound me. I mean, I'm astounded. $500 million, and that's a lot of money. Yeah, yeah.
The process of steady growth,
Yeah.
and it hasn't stopped.
Yeah. And I think when I first became a board member, we were collecting somewhere around 70 cents on the billed dollar, and now it's less than 30 cents.
Yes.
You know, so
Yeah.
it's amazing change. Okay, thank you. We are going to. Are we going to take up the budget estimate now?
Go ahead.
Your option, Mr. President.
Yes. Why don't we
At your
freshen our minds?
Okay, Mr. President, item A, resolution number 1189. Mr. President, I move for adoption of resolution number 1189, which is the budget estimate for fiscal year 2018-2019. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operations to promote charitable and community service mission of the district.
Thank you, Dr. Nicholson. Do I have a second?
Second.
Thank you, Dr. Stewart. And any comment you want to make? We already
I just want to
commented
thank
on.
you. I know it was a long presentation, but it's a little bit more complicated this year.
Oh, yeah.
Need to make sure everybody's got a good grasp
Oh, yeah.
of what's on the table.
Yes, indeed. Laura, please take the vote.
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Thank you, Laura. The motion passes. Okay, we're going to move on to the minutes of the May 9th, 29th, and 31st meetings.
Well, Mr. President, I move for approval of the minutes of May 9, 29, and 31.
Thank you.
Second.
Thank you, Dr. Stewart. Laura, please. Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, so that motion passes. Are there any oral communications this evening? No? Okay. Dr. Soy, written communications, please.
Thank you. So for tonight, we have two new applicants to the medical staff. We have Jennifer Satariano, a nurse practitioner in emergency medicine, and Linda Hopkins, an MD, maternal and fetal medicine. Temporary privileges were extended to Jennifer Satariano. And reappointments for 2-year include the following: Dr. Ario Barzin, plastic surgery; Dr. Sumbal Beg, endocrinology; Dr. Christopher Carpenter, pediatrics; Dr. Fulton Chen, physical medicine rehab; Dr. Yasser El Sayed, maternal and fetal medicine; Dr. Stephen Franzino, orthopedics; PA William Gade, physician assistant; Robin Goldman, MD, pediatric hospitalist; PA Kelly Hawes for surgery; Jan Hensdorf, MD, orthopedics; P.A. Lai Chiang, Physician Assistant for Medicine. Savitha Krishnan, M.D., Gynecology. Dr. Joseph Kwok, Anesthesiology. Dr. Simon Lee, Pediatric Hospitalist. Dr. Nancy Mark, Anesthesiology. Dr. John Paro, Plastic Surgery. Dr. Graham Rodwell, Nephrology. Dr. John Romano, Plastic Surgery. Dr. Barry Rose, Orthopedics. Dr. Alexander Saw, Orthopedics. Dr. John Su, Anesthesiology. Dr. Shikhar Srinivas, Emergency Medicine. Dr. Rita Wadhwani, Pediatrics. One-year reappointments include Dr. Pradeep Kumar, Cardiology, and Dr. Eric Okamoto, Plastic Surgery. Transfer in staff category include William G'day, a PA from provisional to active allied health professional. Dr. Savitha Krishnan, active to courtesy. Dr. Simon Lee, from provisional to active. Dr. Cindy Liu, PA, provisional to active allied health professional. Dr. Nancy Mark, active to ambulatory. Dr. Jayanth Madiria, provisional to active. Dr. Ronald Matuzak, provisional to active. Dr. Doris Nguyen, provisional to active. Dr. David Orenberg, retired to honorary. Dr. John Paro, provisional to active. Dr. Alana Shane, provisional to active. Dr. Shikhar Srinivas, provisional to active. Completion of proctoring and advancement staff category also includes Karen Garn, PA, Dr. Simon Lee, Dr. John Paro, Dr. Elena Shane, Dr. Shikhar Srinivas, Dr. Jayanth Madiria, Dr. Ronald Matuzak, and Dr. Doris Nguyen. Addition of a physician supervisor to Lance Hine with Dr. Wozniak in cardiac surgery, and to PA Christopher Wilkins, Dr. Wozniak, and cardiac surgery. There have been new privilege requests by Dr. John Paro in plastic surgery, and there are delete privilege requests for Sumbal Beg in endocrinology, Dr. Jan Hensdorf, orthopedists, Dr. Joseph Kwok, anesthesiology, Dr. John Paro, plastic surgery, Dr. Graham Rodwell, nephrology, and Dr. John Romano, plastic surgery. A leave of absence has been extended to Dr. Alan Spira in emergency medicine, and resignations include Dr. Ann Burton of internal medicine, Dr. Sunitha Kaiser, pediatrics, Dr. Bethany Woomer, pediatrics, and Barry Towers, a perfusionist.
My goodness, you've been busy.
Yeah.
Well, all these doctor privileges, we need the revenue to handle all the expenses we're going to have here. Okay, well, thank you. Can I have a motion for approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Choi.
Thank you.
Second.
Thank you, Dr. Stewart. Laura?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Eben.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, motion passes. Okay, Jeannie, good evening.
Good evening. Greetings from the volunteers. Another great month. Last month, the Cuddlers were treated to a wonderful in-service by one of our neonatologists, Dr. Rostami. We've been noticing an increase with opiate use and abuse affecting our babies. And so she wanted to address that issue with us because these little babies are born with opiates or drugs coursing through their little bodies, and they go through withdrawal like an adult would. And it affects so many of their systems. They can't eat, they can't sleep, they cry continually, and normally the treatment is they will wean them with methadone or morphine. And the exciting thing was that Dr. Rostami wanted to pass on to us was that there was evidence-based research that has shown that babies that are cuddled, these babies that are withdrawing, they need less medication, they stay in the hospital fewer days, and they've noticed increase in cognitive development. And so it was really encouraging for the cuddlers to hear that what they do because they love to do it has such a wonderful impact on the lives of these little ones that just innocent victims. And so she's looking forward to implementing more programs where they can start decreasing the amount of medication that they give these kids and increasing the amount of time that they're held. We're calling it hugs, not drugs. So we're really excited about that. And the second thing I wanted to share with you real quick is we're celebrating the 40th birthday of our magic hankies this year. In 1978, volunteers started making these. They're called magic hankies because you start with a 12-inch handkerchief, and I hope you all know what a handkerchief is.
Yeah.
Not everybody does these days. But with a few magical stitches put in there strategically, it turns into a bonnet. And we have, for 40 years, been giving these to the mothers who have their babies here. And the tradition is they put it on when they're discharged, then they go home, put it away, and on that baby's wedding day, they bring it out, remove the little French knots and little stitches, and it becomes a handkerchief that the bride can carry. So it's a wonderful keepsake. I got 2 when I had my babies here, and it was a really special privilege to be able to give it to them on their wedding day. Wow. I don't know the volunteers that made them, but it just was just very memorable, and there's a little poem that goes with it. So all our moms are still getting these after 40 years. Lots of hospitals have abandoned this project, but we continue. So
Wow,
anyway,
that's wonderful. That's
40-year-old handkerchief. Happy birthday.
Thank you, Jean. Okay, Dr. Tsoi.
So my medical staff report, we have a grand total of 592 members, of which 348 are active and 96 are ambulatory.
Thank you. Thank you. Okay.
We'll start with the video, please.
Past health promotions and outreach events. On Wednesday, May 9th and May 22nd, Dr. Harpreet Dillon, Internal Medicine, presented Strategies to Help Lower Your Cholesterol and Blood Pressure. 20 people attended. On Thursday, May 10th, Dr. Sunil Dewan, dermatologist, screened community members to help detect skin cancer before symptoms occurred. 15 people were screened. Of those, 11 were recommended for further evaluation. On Saturday, May 12th, Washington Hospital participated in the Age-Friendly Health Expo organized by the Tri-City Elder Coalition. Washington Hospital and Washington Township Medical Foundation staff provided osteoporosis and blood pressure screenings along with heart health information. Washington Hospital was also a sponsor for this event. 73 people were screened for osteoporosis, 120 people received blood pressure screenings, and more than 2,000 people attended the event. On Thursday, May 17th, Michelle Williams-Smith, Senior Family Advocate, Family Education and Resource Center, concluded the Mental Health Education Series with her presentation on family support, caring for those with mental health disorders. 36 people attended. On Thursday, May 24th, Washington Hospital hosted Celebration of Life. This event featured stories of survival and hope for cancer survivors and their families. The event was co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, UCSF Washington Cancer Center, the American Cancer Society, and Tri-City Voice. 73 people attended. On Thursday, May 31st, as part of the Family Caregiver Series, J.B. Goodyear, Spiritual Care Coordinator and Certified Meditation Instructor, presented Mindfulness Meditation for the Caregiver. 17 people attended. On Friday, June 1st, Anna Mazet, Registered Dietitian, presented a Fun Fresh Summer Cooking Demonstration. 21 people attended. Also on June 7th, as part of the Diabetes Matters series, Dr. Kuniyoshi Kanai presented InHealth. Dr. Kanai discussed the increased risk diabetics have for developing eye health issues. 15 people attended. Upcoming health promotions and community outreach events. On Thursday, June 21st, from 6 to 8 p.m. at the Washington Township Medical Foundation Nakamura Clinic Conference Room in Union City, Dr. Tam Nguyen will present preventive screenings? When and why are they important? On Thursday, July 10th, from 7 to 8:30 p.m., as part of the Caregiver Series, J.B. Goodyear, Spiritual Care Coordinator, and Father Jeff Finley, Palliative Care Coordinator, will present Codependency and the Caregiver. Bay Area Healthier Together. Washington Hospital and ABC7's Bay Area Healthier Together programming continues to raise awareness and educate the public about health issues and healthcare resources. In the month of May, Bay Area Healthier Together featured minimally invasive spine procedures as well as pituitary tumors and gamma knife treatment options. More information is available at bayareahealthiertogether.com. The Washington Hospital Healthcare Foundation Report. On Saturday, October 13th, the Washington Hospital Healthcare Foundation will host the 32nd Annual Top Hat Dinner Dance. This year's gala will be chaired by Marcia Badella, Dr. Carmen Akawili, Medical Director of the Intensive Care Unit, and Dr. Kadir Halimi, Medical Director of the Emergency Department. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the support of the new intensive care unit in the Morris Hyman Critical Care Pavilion. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended Indo-Americans for Better Communities Charity Ball on May 12th. Washington Hospital Employee Association, WIA. In May, WIA held its annual wish list event in which various hospital departments submit non-budgeted requests for patient care items. WIA awarded $8,678 for items such as a wheelchair for admitting and exercise equipment for outpatient rehab and cardiac rehab. Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels WOW Mobile Health Clinic returned to our district in early May. Preparations are being made to provide healthcare services to our community members in the district. The Mobile Health Clinic was at the Age-Friendly Health Expo on Saturday, May 12th, where staff provided tours and answered questions about services that will be provided. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's About WHHS was May's most viewed webpage with 38,700 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78, InHealth, captured new programming, including a health and wellness program titled Strategies to Help Lower Your Cholesterol and Blood Pressure, 2 mental health education programs called Mental Wellness and Family Support, Caring for Those with Mental Health Disorders, and a Caregiver Series program on mindfulness meditation for the caregiver. In addition, InHealth aired 3 health and wellness programs called Wound Care and the Latest Treatment, Stress Management, and Sick Feet, the April Citizens Bond Oversight Committee meeting, and the May Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
It's my pleasure now to introduce to you Adrienne Jackson, Senior Application Analyst for our Information Services Department. She's our June Employee of the Month. She's truly a homegrown product. She attended James Logan High School, where she joined an ROP program to explore opportunities in healthcare. And after high school, she completed her medical assistant training program and began an externship at the Newark Clinic of Washington Hospital. She knew right away it was a good fit and said, helping others comes naturally to me, so working with patients just felt right. She was hired in 2002. She worked as a medical assistant in Newark until 2007, when she transferred to the Warm Springs Clinic, and she was promoted to lead medical assistant, overseeing the medical assistants of the Warm Springs, Newark, and Nakamura Clinic in Union City. When Washington Hospital chose Epic as its electronic medical record system, Adrienne was recognized as an expert in her area and was recruited to join the implementation team. And she says, that's when my IS journey began. She approached her new position like she had all of her roles in the past with the hospital, with dedication and perseverance. Last year, she was promoted to senior application analyst on the ambulatory team. She says, we have a great team. Every day we think about the patient-first ethic, and everything we do, we ask, how will this impact the patient? Her manager, Director of Ambulatory Care Applications, Michelle Smith, says that one of the special things about Adrienne is her work ethic. She shows pride in her work. She makes sure to understand the impact that changes in workflows have, not just on the ambulatory side, but on the entire organization. From the medical assistant program to a member of the information services team, she's had no idea of the range of opportunities that a high school ROP program could lead to. She says, I enjoyed working with patients, and now I feel I'm supporting them in a less direct but equally important way. When not at work, she often spends time with her family. She enjoys providing comfort food to her sister, mom, and dad. Her culinary adventures recently produced a Cuban dish, ropa vieja, which was a flavorful hit with her family. Another hobby is shopping for watches. So when the Employee of the Month gifts included a watch, she was absolutely delighted. She was surprised by her recognition. When John Lee announced in their quarterly meeting that a member of the IS team was being recognized, she had absolutely no idea who it would be until her name was mentioned. And she humbly noted at that time, I must be doing something right. I think so. So congratulations to Adrienne. We're very glad that she chose us.
I had no idea that the size of the information services department was, it's got to be 80 plus people. My goodness. Wow.
Yeah.
Takes a lot of people to manage Epic and the systems of the hospital.
It is, excuse the expression, a very invasive system.
Yeah. Yeah. Yep.
And we absolutely need their help,
Sure.
which they provide extremely well.
Yeah. Yeah. Okay. We're going to move on to the lean report then.
Okay, I'm going to introduce our three speakers, although I believe they're well known to the board. Our first is Stephanie Williams, and she's been our hospital now for almost 20 years. She's a registered nurse with a master's degree in healthcare administration and is a certified professional healthcare quality. She's certified in professional healthcare quality as well as lean. She is our current chief nursing officer and associate administrator. Oversight responsibility for quality and resource management, health information management, patient care services, including all the med-surg areas, critical care, stroke, emergency, the special care nursery, and maternal and child health departments. She was previously the chief of quality and resource management, in which she had oversight of quality, case management, social services, spiritual care, and diabetes. Also speaking tonight is LV, Ballard. She's a registered nurse with a bachelor's degree in nursing. She began her career at Washington Hospital in 1998 as a bedside nurse in our ICU. She holds specialty certifications as a clinical nurse manager, leader, and critical care registered nurse. She's grown professionally in her 20 years here and is currently the nurse manager for the critical care and intermediate care units. And no stranger to us is Dr. Carmen Akawili. She began her career at Washington Hospital in 2008 as the director of the intensivist program for critical care, although she'd been a long-term member of the medical staff prior to that. She is board certified in internal medicine and critical care. She is also a fellow of the American College of Chest Physicians and a member of the Society of Critical Care. She's been practicing medicine in Fremont since the early 1990s. Currently, she's a medical director of critical care and intermediate care units and is the medical director of the Ohlone Respiratory Care Department. She's also the co-medical director of the Palliative Care Service at Washington Hospital, which began in 2016. With that, I'll hand the program over.
Thank you, Nancy. Can you feel the excitement in the air? It's long overdue. So tonight we're here to present the work that's being done in terms of transitioning the critical care unit to the new building. I am the executive sponsor for the transition program. When we began the process of planning the move, the executive leadership recognized that a lean methodology of 3P would be the ideal approach to help us guide the design to lead a seamless and efficient transition and also provide the best quality of care to the community. Again, it's based on the patient-first ethics, with the patient being the center. Tonight, we're going to share with you an overview of what our team has done to prepare for this move. So what's changing? We currently have 28 beds, and we will have 48 beds in our new building. We will have a larger space, large window with spectacular views. We will even have outdoor access for our patients. The patient rooms will be bigger, more comfortable for the family, and we hope to get the family more engaged in the patient care plan. With this new space comes new challenges. The caregiver is going to be further apart. There's going to be a lot more separation, and there will be more distances to access other services in the hospital. So some of the current processes that we have now will not work in the new space. So therein lies why we have gone to that 3P approach. So why work on it now? We wanted to engage the staff and physician because they're the ones at the front line. We wanted to get their feedback, hear what they're thinking, get them involved in the decision making. We want them to be invested in the move. By addressing some of the concerns and the challenges that they have right now, we are going to be able to develop the workflow that's going to work both for the patient and for the staff as well. Developing these new processes will allow us to know and understand what resources are needed and how to use them efficiently. Currently in the ICU, everything is a few feet apart. The nurses are right next to each other. So looking at that, understanding that process, and knowing that the rooms are bigger, we have to think differently in terms of how are we going to be able to provide the same level of care and yet be comfortable in the space that we are. We are very excited about it. It's challenging at times. So tonight you're going to hear from Elvie in terms of the 3P process, and Dr. Aguilili is going to tell us about some of the coordination workshop that we have done. So with that, I'll turn it over to Elvie.
Good evening, everybody. Good evening. So why did we choose Lean to help us prepare for moving to the new building? Well, Lean is part of our culture. It's continuous improvement. You probably heard Kaizen repeated several times here tonight in this presentation. Kaizen is a Japanese word meaning to change for the better. So that's what we want to do. We want to be better and always continue to improve. So the lean methodology of 3P, which is production, preparation, and process, helps design new processes for a radically different physical space. And that's exactly what the ICU is doing. We're going to a radically much larger physical space. There's also 5S, which is sort, set in order, shine, standardize, and sustain. This helps us organize the space and supplies before we move in. You can kind of call it similar to spring cleaning, where you set your thing, you want to organize your stuff that's in the garage. You set it in order. You might want to dispose some of it, but it's not really spring cleaning because over the following months, it's like in our household, we tend to accumulate stuff again, and then we have to repeat it in the next year. 5S is different because you sustain it. You sustain the workplace, you sustain the environment, you keep things organized for more efficient workflows. And lean leadership is also helps promote transparency of issues before they become barriers and before they become problems. Here we have the 3P methodology that we use. We help the teams envision the process. Then they had to design the best product that would help determine how to best meet the patient's needs. Because we had to make sure these processes and new processes would benefit the patients and families, the staff especially, because our goal is to optimize flow and the value for patients and families. Here is an A3 document in Lean, and this is our team charter. We were challenged with the improvement request from our sponsor to develop new workflows for staff in the unit, paying specific attention to the new space. We were also challenged to design equipment supplies to maintain efficiency and to develop signaling systems, which is consistent across all departments that are locating to the new building. With that, we made a mission for ourselves is to provide the highest quality, evidence-based care to all critically ill patients and their families. And our vision is to engage the patients and families. We want them engaged and in the comprehensive, highly coordinated, interdisciplinary care with the human caring touch. Stephanie Williams, our Chief Nursing Officer, challenged the teams. Always keep the patient at the center. Follow our patient-first ethics. She wanted us to take what we have and provide the best possible care. She reminded us it just wasn't about nursing and physicians, it was about the whole team. So we did that, and we did stay focused on the process. We had a total of 5 workshops, and we made sure that the team members were multidisciplinary. We had any ICU nurses and MDs, and the intensivists joined us. We had ED physicians, we had pharmacists, we had clerks, because we wanted to make sure we had their different perspectives and ideas so that we come up with the best processes for our patients and our staff. So we had a workshop on visioning, 3P flow design, care coordination, medication and pharmacy, and another one on care coordination, focusing more on communication and handoffs. Going to the Gemba, this was the fun part. Gemba is a Japanese word for workplace. We cannot make changes or decisions without knowing really what's going on in the workplace. So here you see a group of us getting ready to tour the new building. It was really quite fun and exciting. So I can't imagine going into a new building now that it's all ready. That's going to be a lot more exciting than when we had all our gear on. We also have a mock patient room that we also got to experience so that we could plan the processes by envisioning and actually seeing what the new rooms will look like. So in our 3P flow design workshop, our goal was to understand the different flows within the ICU. So we went to the Gemba, and we used lean tools to observe the staff at work. And what stood out there was that there was quite a bit of interruptions for the staff to provide care. There were so many numerous phone calls, either that they received from staff or that they had to make themselves just to coordinate the care or schedule. There was also multiple calls from family members. Understandably, they wanted to know how their loved ones were doing. So with this, the teams decided to focus on information flow of information between the staff, between the family, and also to consider the physical flow, the movement of patients and staff. As you can see here, we made a stick of our staff, and it took about 18 staff members, very large care team, to just transfer a patient from the emergency room into the ICU to be admitted. That includes the ICU team, the ED team, bed controls was involved, respiratory, there's transport team that was involved, even our environmental services staff was involved. So it really, truly takes a whole village to take care of one patient. And with that, we knew all of this communication that takes place needs to be accurate, consistent, so that way the care can be more coordinated. So our target condition was to develop standard work. We wanted Epic to be more robust with the signaling systems, and we wanted to have communication strategies to promote that efficient value flow of information. So our outcomes of this workshop was we were able to better understand our communication needs. We got the staff involved, and they had the opportunity to go to a phone fair. They got to choose the best phone systems that would meet our communication needs, and it's actually going live next week sometime. Yeah. So we're excited about that. The process for communication between ICU intensivists and the ED MDs were streamlined during their consultations. We improved that flow. And in addition, there's a bed tracking board that is currently being developed for house-wide use. To consider the future state, at the time that we went there was probably around October or November. The building really wasn't completely built. It was partially built at that time. So we created a 3D model to allow us to understand the physical flows of how patients and staff would move about in the new building. We considered the radiology access for the patients, and we also considered looking at the services in the main hospital. The time, how long would it take to transport the patient from the Morris Hyman Pavilion to the old building where the services of cath lab and OR is. We even considered the congestion and the elevator availability. We also took a look at routes that we would take so it would be more efficient in terms of which way to go. Since the ICU charge nurses respond to code blues and sometimes to rapid responses, we looked at that process as how would it work now when we have two buildings and two different areas to cover. We knew that there would be challenges with communication flow between the care teams, and we wanted to make clear, consistent expectations for visiting family members. So looking at the physical flow, we decided to start within our own current unit. So when we did 5S in our current space, which is much, much smaller, we thought it would be easy, but we found that we really need to do the 5S process there. We wanted to understand what supplies and equipment did we really need to bring to Morris Hyman Pavilion. We didn't want to bring excess items that would be unneeded. We also wanted the staff to get used to the standard of 5S methodology for maintaining our workspace. And we wanted to standardize across all areas of the new building in line with the current standards. The challenges we saw was that besides being the larger space there, we will have 5 different pods, 5 nursing pods. The configurations in the nursing stations are all the same, but the storage areas are a little bit different in layout, so we had to take those things into consideration. Oops. Here is the ice in the current ICU. We did sort and set. We were able to empty out 9 out of 21 drawers. So that was quite a bit of supplies and equipment that we had cost savings for. We didn't realize we didn't need all the supplies. It was amazing. The staff were just like, really? and truly, really, we did not need all of those supplies. So we organized it, and now we have more efficient use of our drawer space. And what we did too is we strategically place items for staff so they would have what they need, when they need it, and in just the right amount. Here is our alcove equipment area that you see the before and after pictures. Now we have standard work. We use visual management. We have pictures and keys on the floor so that we know exactly where the equipment belongs. It's not just a hodgepodge of just pushed into a corner now. And this also helps us during emergencies when we need the equipment, we can readily access them. Here's another example of what we did in our 5S. Now we have things labeled correctly, they're color-coded, we use that visual management, and we have correct PAR levels. So with that, with us going through this 5S, we now know and realize what equipment and what supplies we should bring over. It gives us a good idea, and we know that we can manage, even if the space is big, that doesn't mean we have to have all these excess supplies. Okay, so next, I would like to have Dr. Carmen Akawili come up.
Okay, thank you. We're excited to have this new house, but we know that there are a lot of problems. So we have to be more organized, efficient, and with good flow. So on the next workshop we did, we identified for care coordination was the interdisciplinary rounds, the daily care coordination, and family engagement. Imagine it's a big room and you have to make rounds on all those kinds of patients. So we need to be very efficient. So we said we're gonna start the rounding time at the same time each day, 10 o'clock after medication has been given and everything. There should be mandatory attendance of each discipline. The RT should be there and things like that. So mandatory, if they can't come, somebody else needs to take their place. We emphasize on the multidisciplinary participation. We're reducing the overall time and eventually per shift, but we want to improve the delivery and the content of what we need to report. So because of that, our IT Epic people help us to create the new ICU Rounding Navigator in our Epic. And it pulls the most recent recorded events in terms of the background, the A to F bundle, where's the patient, and at the end, what's the plan for the shift. So everything is there. It's so easy. By 1 or 2 clicks, you'll be able to give your report. So that has decreased the time, and when we standardize it, it's about 1 to 2 minutes per patient. Hopefully we can do that, because sometimes some people discuss a lot of things, but now that we have standard work for each of the discipline, we also know the timing. After the A, the nurse says is, B will be breathing, is respiratory, so they already know their roles. So hopefully that will help. And then for the daily care coordination, we shifted our goal to the patient. What is the schedule of the patient? This kind of patient, what is going to happen? So mealtime, and then rounds, and in between physical therapy. It's important to know what will happen to the patient so that we decrease the phone calls. For the clinical as well as the non-clinical needs of the patient, procedures and medical care timing is scheduled. So there's more to it in the next workshop. And then family engagement. They're already participating. We invite them to the interdisciplinary rounds if they're there. But aside from this, we're also develop the web-based ICU-focused web page for them. If they want to introduce them to the family and visitor policies, our educational program. But for those that are not computer savvy, we still have the brochure. We updated the brochure. And most of all, we will not forget about the patient diary, the patient family diary, which we give to each patient in the hospital so that they can write down the events of the day and they can bring it home. The next workshop we did, is very important, is the medication and pharmacy. So the challenge is medication flow of safe delivery, because the main pharmacy will be in the old building, and we need to make sure that the delivery is safe and timely in the ICU. So there were recommendations for timing of medication administration. There's scheduled medication delivery every hour. They deliver the ones that are needed. We already have medication on the Pixies. And then for STAT, anything that can be used for the pneumatic tube system, we use that and maximize its use. And also, for those that we can't do anything but have a person deliver it, that's also done. But we minimize that and maximize the other uses. We try to improve communication also from pharmacy to the nurse by creating, again, EPIC, EMR, help us with the visual status board, where we know where is that drug from the pharmacy to the delivery. We started only with the STAT drugs, the drugs that we needed most. And we went back to the care coordination and handoff. We thought that this is very important. Communication is important. We need to know specialty to specialty, nurse to nurse, doctor to doctor, how we hand off that patient that comes from ER or from the floor. So what we did there is develop standard work for verbal as well as EPIC communication. What usually happens that for the verbal, we created like what is the content of the verbal. And then for the handoff in EPIC, usually if you're the nurse, you will get that information and bring with you and call the nurse of for example, ER to the ICU, and they discuss important things. So you have two, and you are maximizing the information that's needed. And then the other thing that we did was the care coordination. Initially, before we said about the patient scheduling, again, EPIC, the IT team, has helped us build the patient daily plan. It's like a schedule, a daily schedule plan, where on this side you'll see that there's a 24-hour schedule, and it gives you the things that are needed to be done. And in between, if you need an EEG, you can get the EEG at 8 o'clock. Physical therapy will look at the schedule and say, oh, I can schedule my time at about 2 o'clock in the morning. So 2 o'clock in the morning, I'm just kidding. I just want to wake you up. 2 o'clock in the evening. So by doing that, you reduce the number of phone calls and you reduce the miscommunication. So we're testing this, and we're hoping that this will be better and will increase communication. So we'll start with EEG, with echo, then hopefully radiology in the future. So lean management is the key to sustaining, of course, lean goals. So we continue to develop people or staff, all of us. We create accountability for all of us. We try that. And we align the improvement of work across all levels: associates, supervisor, the frontliners, intensivists, and physicians. So our next step is to plan to have workshop to set up the new space, beginning with patient care. The goal is to standardize across the building. We'll continue our plan, do, check, and act to implement and optimize the new processes developed during workshop, and coordinate with other departments moving to the standardized process.
Hi. On behalf of the critical care team, I want to thank Nancy Farber, our CEO, Stephanie Williams, our Chief Nursing Officer, and Dr. Carmencita Acawili, our ICU Medical Director, for their continued support and encouragement. Plus, they're always pushing us to do better, pushing for excellence, pushing for excellence. So with them, I feel like we're a great team. We do push for excellence, and we're really excited and happy to be moving soon. It's only a few months away. But also, I want to give recognition, I'm almost forgetting about them, the team that helped us with develop these new processes, and for the critical care team also as well, because for them being early adapters, for helping try out these new processes, as they know we need to get ready and be prepared for the fall. It's coming soon, so thank you. We're very excited to move into the new home, the Morris Hyman Critical Care Pavilion. Thanks.
Thank you, LV, Stephanie, and Dr. Aquilini. Thank you. Any questions?
It's great stuff.
Excellent, excellent. Okay, okay, Ed's going to get up and.
Yep.
Is this going to be the final construction update?
No, we're never done building.
No, no.
Perpetual construction.
It's a perpetual process.
Yes, unfortunately, no, it will not be the final.
Okay.
What happened to my slides here? Okay.
There you go.
Thank you. So, I do have to say, you've heard it multiple times tonight, but I do have to say that we did meet our date for staff and stock, and I would be remiss if I did not make a comment about Rudolph and Sletton. They had actually provided this schedule 3 years ago, and they were the ones that told us this was the date for staff and stock, and they went above and beyond this last 45 days to make sure that we hit that date. You might remember, I think it wasn't that long ago, I said we had to move the staff and stock date to the end of June, and they took it basically as a personal challenge to get this thing done on time and meet their original schedule, and they did do that with the assistance of Jacobs Engineering and the architects and the inspectors of record, but they did complete their work last Friday at about 8:30. I got a call 8:30 at night that they were done and on time and on the date they promised. So I do have to commend them for that work.
It's totally remarkable.
Yes, I think committed is probably the right word in terms of what they've been to us and a partner, really. This gives you, I think we've looked at the main lobby here multiple times, but you can see it here getting sort of its finished look. On the right-hand side, you see sort of a bare wall. That is a wall that will have an exhibit of everything from the history to the community commitment to the hospital and the donors and such as that. So that'll be developed and will be installed just before we have our open house. Here you can see that they're testing the different fire alarm portions of the fire alarm system. These are smoke curtains that go down in front of the elevators in the event of an alarm going off. You can see the CT scanner is basically in finalized condition. I think they still have to have the physics final sign-off from the contracted out physicist. This is just a little shot of, this is the ER waiting area, and there is a separated children's area of the waiting area. This gives you a little bit of a look that also the landscaping is in. So a couple of weeks ago, plants and trees started showing up, and they have been, the area all around the emergency, the whole building has been planted as well. The only area that's not planted is the very far reaches of the property over where the helipad and that formerly was, and that'll be planted before the end of this job. The canopies for the emergency room are completed, and as you can see here, the asphalt has been laid down, and you start to get more of a finished look to the entire building. Again, canopies, lighting included in the canopies. This is just showing you a shot of the loading dock. There's a ramp up the middle of it for deliveries, as well as the truck drop-offs. And you can see the steel infrastructure getting finalized, and probably more impressive as you can see that the back of that loading dock is starting to get the exterior skin, and this will be the enclosed corridor between the two buildings. This gives you a look at where we are with the first floor connecting corridor that's outdoors, so you can see the steel and the canopies have been put in place, and they're making good progress in this area as well. Also, as you can see, is where we are in the phase of construction. This will be the last part that will be done in terms of what will be physically visible and needing to be operational before we open up. After we open up, there will still be some work going on, as we've talked about, the helipad area, some areas of the existing loading dock get modernized. So there's still going to be some work after we open, but this is the last part that needs to be in place before we do open. This was a late addition to our project, which was sort of an emergency exit from the emergency room for cases where we need to get over to the main hospital immediately. This was added, and so this is why it's in one of the later sections. You can see they had to remove the skin, put in new infrastructure, and the door is already in place, so it's going to be closing it up between now and when we open. So this, you can see it's aligned with the canopies, so you come out of the building and you're making your way under covered walkway all the way to the new hospital for those emergencies like heart attacks that you need to get to the cath lab right away. This is the east side, the back side. You can see that canopy and entryway is also finished up, and this gives you more of a finished look of where we are now. So yes, there's still going on, as we've talked about multiple times. The connections, the exteriors, those things will be going on. I'm sure I'll be continuing to give you some reports on that. But yeah, the inside is pretty well done. We have those relatively minor in the scheme of things, like that exit out of the ED, some things that we have to do in the psych rooms that are for anti-ligature with late Joint Commission requirements that weren't available to us when we designed the building that we've got to make it compliant with now. So we've got things like that that are going on, but the lion's share of the work inside is complete at this point. Okay.
Okay, any questions? Thank you, Ed. Thank you. Okay, Nancy, we're going to go to the quality.
We'll have Mary Boron come up and give the report.
Yep, sure.
Good evening. Tonight I wanted to focus on a very specific part of quality that relates to how we measure nursing practice and how their skill set and their backgrounds and their education really impact patient care, otherwise known as nursing sensitive indicators. The standard definition for a nursing sensitive indicator are indicators that show the care of quality measures that are sensitive to the provision of nursing care. So again, reflecting on what nurses do at the bedside with their skills and how we can attribute those to the outcomes our patients have. They focus on a reflection of structure, process, and again, the outcomes. Nursing sensitive indicators started to develop around the early to late mid-1990s. It started off with the American Nurses Association launching an initiative that focused on patient safety and quality. And as the end of the 90s came along, they actually moved further into establishing a database to where we could all hospitals across the nation could send in their data that was related to nursing practice in a database that they called the National Database for Nursing Quality Indicators, otherwise known as NDNQI. And this really gave a lot of a great place to composite all of the data together and allow us to benchmark it against other hospitals in the nation. And then we moved into 2002, where Joint Commission really started to incorporate looking at these indicators also to measure nursing practice. And towards even 2007 and 2008, Medicare started to get on board with this and recognize that there was good research and evidence-based practice around looking at these indicators. And that's where we started to get even further into the federal agencies looking at our nursing practice. The main purpose of why we look at nursing sensitive indicators is because we've been able to establish that when you're measuring the practice of a nurse and you're looking at the evidence of how they do their skills, and you can actually directly measure them to improved patient outcomes and learn a lot from looking at that practice. It also creates a culture of excellence. There's a lot of discussion around nursing data and indicators, and especially when you're comparing yourself to other hospitals in the nation, really creates the desire to strive for the best practice in nursing. Nursing sensitive indicators that are specific for us here at Washington Hospital are allowing the staff to be informed about what's happening, even specifically to their units, with data that we can specifically identify as occurring out of their practice area. And we give this data and provide it typically on a quarterly basis. They are getting it by unit fairly often. And we can monitor trends and outcomes to see where we can make our improvements. This is a big focus of the magnet designation, which I know most of you are all familiar with. But just to review, it's a designation provided by the American Nurses Credentialing Center that really expects nurses to be practicing at a higher level than the national benchmarks. And we have been able to attain that magnet status. We were first received it in 2010. We were redesignated in 2016. And even currently in 2018, you still only have about 9% of hospitals that have achieved this level of designation. So it's been a great success for us. Even recently, we're starting to rev up again and focus on our approach to getting this designation again and being able to maintain it. Some examples of what we look at and what most of the nation looks at with nursing sensitive indicators are the structure of your care. How are you educating your nurses to make sure that they have the skill set to provide appropriate care? Process of care. What are the processes that we do every day in the hospital, and how can we make improvements to help the patients? And then we have a set of nursing indicators that are very focused to different procedures that they perform and looking at how those impact patients. So to get further into the structure of nursing education, as we all know, healthcare has evolved and is very complex, and it's changing continually. And one of the parts that we can really offer nurses support is by making sure that they have the proper education and the training to do and live at the best level of their skill. And our national organization, which is otherwise known as the Institute of Medicine, IOM, they set what was when they set this as a pretty high standard. They decided that they thought that nurses should achieve 80% of our workforce should be able to have a bachelor's by 2020. And I think that really has led to a lot of hospitals looking at making sure that we're getting nurses educated as well as possible. But here specifically at Washington Hospital, even as far back as 1992, we started new grad programs with trying to attract a nursing set that came in with a Bachelor of Science in Nursing. In order to achieve what we have, which is 77% of our nurses today in this hospital have a Bachelor of Science in Nursing. That's a huge success, considering that the IOM was saying this high standard to us to reach 80% by 2020, which is our goal, obviously, and we're very close to it. In order to do that, though, you really have to have strong buy-in and support from leadership. And I think that one of the things that has helped us achieve this is the fact that there's been continuous support from Mrs. Farber to support the development of new grad programs. We offer tuition reimbursement. There's a lot of support in general to encourage people who are even currently working in the hospital that if they have an associate degree, encouraging them and giving them some support to even move up into getting their Bachelor of Science. And new grads who are hired here also are required to have a Bachelor of Science. So that's how we've achieved that. And in addition to that, you need a lot of support from your chief nursing officer. And Stephanie Williams has been very involved in new grad programs, has always advocated for them, even at times where it was difficult to come in and request it. It's an expensive program. You have to put a lot of investment up front in these students, but we've achieved an enormous response and rewards from being able to do that. We've been able to retain 75% of our nursing new grads on a long-term basis. So I think that really gives a good foundation and it gets us moving more towards having nursing excellence. Specifically getting into what measures do we look at. Any patient who is admitted to the hospital, especially the elderly population, they become disoriented in their environment. They're on a lot of medications. There's a lot of risk factors that can lead to people being high risk for falls. It's something that nursing is expected to watch very diligently and to put in everything we can possibly to prevent a fall from occurring in the hospital. So here at Washington, we have been able to achieve a lower rate of patient falls compared to the rest of the nation for the past 2 years. You can see we've even been below the benchmark quite a bit. And that has not been an easy task to accomplish. All of our patients are assessed within the first day of admission to see are they at risk for falls. And if they are at risk for falls, we put a signal, which is even the patient will wear a certain type of sock that has gription and support, and it's a color. The national color for fall risk is yellow. They have patient bands. There's all sorts of signals so that everybody who walks in the room knows that this patient is at risk for falling. We've worked with national databases that Joint Commission supports to make sure that we are doing the best, most current practice to prevent falls, and we have also really put some good people present, constantly rounding on the units. So we have CNAs, the charge nurse, everybody's involved in making sure that they can keep their eye on that patient and that we can decrease the risk and keeping them visibly near the nursing station, things like that. In addition to that, we've been able to build signals into the healthcare record of EPIC that will sort of alert you. You have this patient who's high risk for falls, so that sort of helps you, another reminder to keep a watch on these patients. We use the best equipment and devices that are out there right now, such as the best kind of beds that are low to the ground, so that if a patient even does have a rollout, it's nowhere near the risk of the same injury. We also use supportive devices when ambulating them to make sure that they don't fall. In the event of a patient falling, we do an immediate debrief fall huddle so that the group gets together while everything is, the event has just occurred, so it's fresh and everybody can relate their facts and look at, what are some of the root causes around this and what could we have done to prevent the falls. So a lot of work being done around that. And another outcome measure, we focus on our hospital-acquired pressure ulcers. I think most people recognize these as otherwise known as bed sores. It's probably a term you're familiar with hearing with this. The action plan that we've been focusing on has been very well developed, and we keep on trying to add different, more current interventions because, as you can see, quarter ending 3/17, we did have a little bit of a spike, and we went above the benchmark. And at the end of last year, a couple more developments of pressure ulcers. And these patients during this period, we really drilled down and did a deep dive on what was it that we think made these patients develop a pressure ulcer. A majority of them occur in patients who are, of course, in bed longer, so you're going to see it typically more often in critical care. These patients are sick. They have a high acuity of illness, tend to not be eating well. Nutritional support for them is very key to watch, but if a patient's not taking in nutrition and has chronic illness, they're at higher risk for developing these. And that's what we saw in those areas where we went above the benchmark. However, we still want to focus on identifying these high-risk patients and making sure that they're being turned appropriately, and if at all we can get mobility and get them up in early mobility, you can prevent the ulcer from getting worse. Another piece of it is making sure that we're documenting what the patient's skin looks like upon admission. Many of these patients come from skilled nursing facilities, and if you do not really do a good thorough skin assessment and document the current state of the skin upon arrival, then you notice, let's say even a day or two later, oh, this person has had some breakdown. The national standard is that they recognize that as the hospital-associated ulcer. So you've really got to be careful on your initial assessment and make sure that you understand how the patient arrived and document accordingly. We're working on that. Another great intervention that has shown some good outcomes for reducing pressure ulcers is making sure that these patients are in the proper bed. They have really advanced beds, and to the point where you can have these phenomenal flotation mattresses. They relieve the pressure and really have helped to show to improve patients' skin and incidence of ulcers. I think there's been a lot of talk in how we manage pain with patients with the opioid crisis, but this particular indicator that we really need nursing to still focus on is how often are you assessing pain for the patient in the hospital. It's something we still have to continue to focus on. And here at Washington, our nurses average 25% more pain assessments per patient per day compared to the national levels. So I do feel like that these patients are getting a face-to-face encounter with the nurses where their pain's being where their pain is being assessed at, and taking appropriate interventions. We've also been able to use the electronic health record in helping us to have reminders about when and how to do that. And we do a lot of staff education and huddles that even go back as far as the unit-based counts are very specific to the unit, giving them data on how they're doing on assessing pain. Another complex area of patient outcomes is looking at catheter-associated urinary tract infections. So again, this is a urinary catheter that's placed with the patient. It's a foreign device. It makes it high risk for developing infection in a patient, especially a sick patient. And over the past six quarters, we haven't had an overall decreasing trend in counties. As you can see, we've had some periods where we did go above the benchmark. Those periods are taken very seriously. Every catheter-associated urinary tract infection that occurs in this hospital is reviewed with our infectious disease physician, Dr. Martin, and she works with a multidisciplinary team to look at root cause analysis. What do we think happened that made this patient get this bacteria in their urine, and what could we do to prevent this and improve our skills here to reduce the development of an infection? Some of the ways that we have done that is by using catheters that are designed and have been shown to reduce the risk of catheter-associated urinary tract infections, always looking at those products, disinfectant wipes, retraining the staff on how to use them, making sure that we only have catheters in a patient if they absolutely need them for medical necessity. That's reviewed every day by the infection prevention and the nursing team, and continuing education around that. Central line associated bloodstream infections, another foreign device that's very invasive for a patient. It's placed in the vein and terminates in a large vessel, where it's great to use this device because you can give medications and fluids and very easily and quickly. However, we do not want the patients to get blood infections from these, so we've really focused on making sure that we're doing proper hand hygiene anytime you're changing the dressing or even accessing the line at all, and assessing every single day, do we need this patient to have this device still? If they need it, that's fine. It's medically indicated. You do everything you can to prevent it from getting infected. However, if the medical necessity is no longer met, that line needs to come out that very day at that point that we recognize that. We also use chlorhexidine baths on patients in critical care. This will also reduce the risk of them getting an infection that may be transferred over from their skin or the outside environment. Dr. Martin also works with us very closely on these. She looks at these, she takes these very seriously. She works with critical care staff on looking at root cause analysis, med-surg staff, and you can see we've had some good success on decreasing those, especially in our quarter ending March 18. Restraints are another very focused topic when it comes to what kind of care are we providing to patients to keep them safe on the units. They're obviously put into place only when absolutely necessary. And in fact, we have noticed a decrease in even the medical staff, the level of where years ago you used to be able to get a restraint order, fairly easy. It was standard. Now everybody's taking a step back and saying, what else can we do to not put these patients in restraints? Nobody wants to, restrain a human being with physical restraints. And in doing that, I think nursing looked at some of their operations and looked at some resources, and we've been able to put what we recognize as called sitters. So that's an actual physical person sitting there around the bedside 24/7, monitoring to make sure that these patients aren't getting up, rather than having to put a direct physical restraint on them. And we've had a great deal of success with that. We have a much lower percent of patients with physical restraints for, it's been over 2 years now. Our future direction with continuing to look at the nursing skill sets and how it impacts patient outcomes will be to just keep on learning by looking at this data. We look at this data frequently. We use our shared governance model in nursing to make sure that it gets to every nurse that it can, and to try and learn and recognize where we need to focus our education on. One of the things that we have also recognized recently, especially when we've been dealing with and talking with magnet consultants, is that we really need to expand this beyond even acute care, looking at what can you do to help patients in ambulatory care areas, and that'll be a focus coming up, moving into looking at nursing quality in the ambulatory care settings.
Thank you, Mary. Any questions, anyone? Okay,
Thank you.
Thank you. Great report. Thank you. Okay,
Guess we're back to Chris Emery again.
Yep.
Not going to get a break tonight.
But I promise I won't talk as long as the last time I was up here.
You got really good numbers this time.
Yeah. Yeah, we had a good month.
Yeah.
So let's talk about April 2018 results for Washington Hospital. Average daily census for the month came in below budget at 153.3. We'd expected 184.8. We had 978 admissions against a budget of 1,106. Patient days for the month came in at 4,599. We'd expected 5,545. Outpatient observation equivalent days were 94 below budget and 122. And our average length of stay was pretty close to budget, but higher than what we've seen in recent months at 4.98. Looking at utilization, the case mix index for the month, pretty close to budget at 1.519. We had budgeted for 1.531. We had 113 deliveries in April against a budget of 169, and I don't ever remember seeing a deliveries number that low. The good news is those did come up in May. Surgical cases for the month were 53 below the budget at 354. That includes our joint replacement cases that came in 8 above the budget at 160. Neurosurgical cases were 14 below the budget at 15. Cardiac surgical cases were 5 below budget at 8. Our cath lab procedures for the month came in at 269. We'd expected 346. Outpatient visits for the month came in 47 above the budget at 1,087. And our emergency room visits landed at 4,061. We'd expected 4,555. So April was challenged for volume overall. Quick look at cath lab activity. Cardiac procedures actually made up the biggest part of the pie in April at 44%, followed by our peripheral vascular procedures at 39%, our non-vascular interventional radiology procedures at 16%, and neurointerventional radiology procedures rounding out to 100%. Looking at productivity, management did a pretty good job of flexing down given the volume levels. Productive FTEs were 135.6 below budget at 1,248. We had 180.4 non-productive FTEs, giving us total FTEs of 1,428.4, 133.7 below the budget. We didn't quite make our full-time equivalents per adjusted occupied bed productivity measures. But when volumes get that low, the folks struggle to get people out, and they surely tried. So I got to give them credit. Jumping into the financials, and first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation used for our audited financials. Not unexpectedly, gross patient revenue came in 14.9% below the budget at $158,911,000. But we had some help in the contractual allowances area. That came in at 73.32% against a budget of 76.77. We did make some adjustments to our contractuals as we're moving into the year end. But the big mover there is we received some of the supplemental pool money that the District Hospital Leadership Forum has been working on obtaining for district hospitals over the last 5 years. We received $2.2 million on the district hospital intergovernmental transfer program, and that's a program where district hospitals are putting up their own money to go and get the federal matching funds that the state is leaving on the table. We also received another $786,000 from the hospital quality assurance fee. So both of those were programs that the DHLF were able to secure for district hospitals. So we ended the month with net operating revenue actually only $445,000 below budget at $43,503,000. Operating expenses for the month came in $663,000 below the budget at $40,646,000. Big movers there were salaries and wages were a lot lower given our lower FTEs. That was offset by benefits. We continue to see some unusually high health insurance claims costs. And our provision for bad debt and charity was $1.1 million above what we expected in the budget. Our private pay really spiked up actually in April at 2.7%. So we end the month with an operating bottom line, actually $218,000 above the budget at almost $2.9 million. Non-operating income for the month came in $505,000 below the budget at $1,255,000, largely driven by not an unexpected unrealized loss in our investments given what's going on with interest rates. So we end the month with a total net income pretty close to budget, a little bit less at a little over $4.1 million. A quick look at our Financial Accounting Standards Board presentation. This is the way the financial markets might adjust our financials when they look at them. Operating bottom line stays the same at almost $2.9 million. We pull out our general obligation bond tax revenue. That's the money we use to support our general obligation bonds interest payments, and we pull out that unrealized loss on our investments to come up with non-operating income from a FASB perspective of $365,000 and a total bottom line of $3,222,000. So are there any questions on April?
Well, I gotta say, when I remember last month when we were looking at the operating indicators, it didn't paint a very nice picture, and
Yeah.
even the first couple pages of your report tonight, the operating indicators were really
tough.
look bad.
Yeah.
But it was great to get that dough from the leadership forum.
Yeah.
Work. That's wonderful.
That group has brought $250 million a year to district hospitals that was otherwise left on the table by the state.
Yeah.
So it's good work that they're doing.
Yeah, and on top of all that, you folks did a great job controlling your expenses. I mean, with the census down, you did what you needed to do with the staffing expense. That was great.
Management really stepped up.
Yeah.
They really did, and everybody understands we're all in this together, and we really work as a team on this.
Yeah.
So.
Any questions? Anybody?
Amazing, almost like a comeback in the last quarter.
Yeah.
I was glad to see those checks come in.
Thank you. Thank you. Go ahead, Nancy.
We're going to talk about May. The gross revenue for May was $169 million. Came in below budget by $10.7 million. And $6.9 million less than a year ago at this time. The inpatient gross revenue of $129.9 million was below budget by 9.3%. And below last year at this time by $8.5 million. The outpatient gross revenue of $47.1 million came in above budget by 3.9% or 1.8 million, and it came in 1.6 million above May a year ago. The major drivers of the revenue variance include cardiac cath lab procedures, which came in above budget by 20. That's a 6.7% positive variance. And this drove cath lab revenue above budget by $2.3 million, or a 19.8% positive variance. Deliveries of 130 were below budget by 39, but might call better than what we were looking at earlier. And this drove the birthing center revenue 7.2% below budget. The emergency room visits were also below budget by 8.1%, or 375 visits. The revenue came in 15.9% below budget. Room and board revenue was below budget by $6.6 million. We had lower admissions and also a lower length of stay, which drove the days below the budget of 822. So that's a 15.4% negative variance. Our observation days were below budget by 56. The overall level of activity drove ancillary services revenue below budget by $5.2 million. In terms of our key statistics for May, our average length of stay of 4.47 was below budget. We had budgeted 4.93. And this was 0.15 days shorter than May a year ago. Outpatient observation days were 56 below budget at 147 days. They were 9 below May a year ago. The average daily census of 145.6 was below the budget of 172.1. It's a 15.4% negative variance. The average daily census was 18.8 patients below May a year ago. Our admissions trends, we came in 6.5% below budget at 1,012, but we were above the prior month by 34. And this looks like, with very early review of what's going on in June, to be a trend that will continue unless everything falls apart in the last few weeks of June. It looks like we're going to have a strong month of admissions. Our admissions by comparison to May a year ago were 78 fewer. Patient days of 4,514 were below budget by 15.4%, and they were 11.4% below May a year ago. Surgical cases in May of 375 were below budget by 21, so we're doing a little bit better in that department. And they were only one case fewer than a year ago in May. The inpatient surgeries were 25 below budget, and 39 fewer than May a year ago. The outpatient surgeries, however, were above budget by 4, and 38 more than in May a year ago. Joint replacement surgeries were above budget by 14 cases. Cardiac surgical cases were above budget by 2. Neurosurgical cases were on budget at 28. General surgical cases were below budget by 37. Cath lab procedures for May of 335 were 7 visits above budget, but 8 below May a year ago. Inpatient cath lab procedures were on budget at 166, but 9 below May a year ago. The outpatient cath lab procedures were above budget by 7 at 169, and they were 1 procedure higher than the same period last year. The procedure mix in the cath lab was favorable. Peripheral vascular procedures were above budget by 21, and they were 12 more than at the same time last year. Cardiac procedures were above budget by 20, and above May a year ago by 23 cases. Neurointerventional radiology procedures came in below budget by 6, and 16 below May a year ago. Non-vascular interventional radiology procedures were below budget by 28, and 27 cases below May a year ago. I think Dr. Lynn was out of town for a good portion of this time. Deliveries for May of 130 were below budget by 39, but up by 17 deliveries from last month. And they were 26 deliveries below May a year ago. The non-emergency outpatient visits of 7,481 came in above budget by 23. And these visits were above May a year ago by 264. Lab visits were above budget by 113. Hyperbaric visits were above budget by 38. X-ray visits were above budget by 40. Operating room short stay visits were below budget by 34. The lymphedema clinic visits were below budget by 61. And the infusion center visits were below budget by 78. The emergency room visits of 4,237 were below budget by 375 and below the same period last year by 539. Productivity indicators. Productive FTEs were below budget by 108.6. We're down flexing with volume issues. Non-productive FTEs were below budget by 1.3. The total FTEs of 1,367.9 came in below budget by 109.9. Total productive FTEs per adjusted occupied bed of 6.02 were above budget by 0.26. Total FTEs per adjusted occupied bed at 6.78 were above budget by 0.36. Other operational statistics. Our surgery center had 474 cases in May. This is 24 below their budget and 34 cases below May a year ago. The clinic visits of 3,403 were below budget by 600 and 472 cases below May a year ago. Payer mix. The preliminary payer mix information for May is not good. Government-sponsored patient revenue made up 74% of total gross revenue, and refer back to the slides that Chris presented during the budget presentation. And you can understand why 74% is not a good number. HMO revenue is 1.9% of gross revenue. PPO revenue is 22.2% of gross revenue, and we had budgeted 23.4%. Private pay revenue is 1.9% of gross revenue, just slightly over budget. Days cash on hand for May ended at 178 days, up 2 days from April. Days of gross revenue and accounts receivable were 55. There were $105,000 in charity care applications pending or approved in May.
Thank you, Nancy.
Action?
Okay, we are now going to consider the action items. We already did the budget estimate, so item B, Dr. Nicholson.
Item B, Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of 5 new Philips EKG machines for a total amount not to exceed $52,650.
Okay, have a second?
Second.
All right, Nancy, did you want to comment?
What we want to do is replace our EKG machines. We have 6 EKG machines in-house. 2 of them are Philips and 4 are Mortara. And we want to replace the Mortara products due to their age, their functionality issues, and the fact that they can't seem to hold a battery charge.
Thank you. All right, Laura, please.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Eapen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Thank you. Motion passes. Item C.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the Schindler elevator upgrades to include lobby vision, hands-free telephones for elevator cars, door equipment upgrades, and LED fixture upgrades for a total amount not to exceed $668,484.28.
Thank you.
Second.
Okay, Nancy, did you want to comment?
Okay, this includes old and new. We have new elevators that are comparatively newer elevators in the central utility plant and the CJR and the loading dock. The lobby vision program would provide remote monitoring of elevator performance, just like we have for the 6 other older elevators in the building. And the total cost to install an interface to display each elevator is approximately $16,762.23. This was a line item approved in our fixed asset budget for this year. The hands-free telephones located in each elevator car throughout the campuses are all different from each other, outdated, and on top of that, they don't meet ADA guidelines. We'd like to replace 17 current telephones in the elevators with a hands-free option. Excuse me. Calls would be completed to a programmed emergency number with a push of a button, and once that call's placed, help is coming. Response light would illuminate. All phones would ring into the security command center, which is manned 24 hours a day, 7 days a week. The total cost to upgrade the hospital's elevator telephones is approximately $38,026.65. This is also a line item approved in the capital budget. The elevator doors, equipment components for elevators 1 through 6 in the main hospital building are old and have become harder to obtain. In order to improve reliability and safety, we're requesting an upgrade to all of the door equipment, including door operator, the clutch, the door hanger, interlock assembly, the closer assembly, the hatch door hanger assembly. The total cost to upgrade the hospital's elevator door equipment is approximately $375,880. This line item is a part of the capital asset budget for this year. Then we have the car and hall fixture upgrades for passenger elevators 1, 2, and 3. They're in our main lobby. In order to repair and bring all the lights and push buttons up to the latest code, as well as make them ADA compliant, we're requesting an upgrade to the car and hallway illuminated fixtures for passenger elevators 1, 2, and 3. This will include vandal-resistant buttons, switches, and braille signage within the elevator car, upgraded stainless steel hall stations to call the elevator, as well as stainless steel hall lanterns above the elevator doors to indicate the direction of each elevator car would be installed. The total cost to upgrade the car and hall fixtures in the 3 passenger elevators is approximately $237,815.40. This item was not included in the capital asset budget, but I can't implore the board more strongly than to seriously consider including it.
You're not going to say going up, are you?
Do you remember in department stores there were floor walkers with castanets, and they would sit in the elevators?
Yeah.
And they'd announce the floors?
Yeah.
If we don't do this, we're going to have to go back to that.
To that.
So the total amount that I'm asking for, which is a mix of budgeted and unbudgeted, is $668,484,000.28.
Yeah. Thank you. All right, well, I don't think we have too much of a choice here.
I don't think so.
Okay, Laura.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Eben.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, that motion passes. Item D.
Item D, Mr. President, in accordance with district law, policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of 50 bedside tables and 50 overbed tables for a total amount not to exceed $32,775.
Second.
Thank you. Any comment?
This is normal wear and tear.
Normal wear and tear.
Yeah.
Okay, Laura?
Director Wallace.
Aye.
Director Stewart. Director Eben.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, item
E. Yeah. Mr. President, in accordance with district law, policies and procedures, I move that the board authorize the chief executive officer to proceed with the purchase of the vascular C-arm for a total amount not to exceed $250,068.
Thank you. Can I have a second?
Second.
Thank you.
Director Wallace. Oh, sorry.
No. I get to explain something.
Yeah,
The C-arm that we're using now is 18 years old.
18.
Its image detail has deteriorated over time, and it is essentially at end of life.
Yeah.
Its image monitors are small, and it makes it harder to see images during surgery. The new C-arm that we're requesting has a flat panel digital detector, which enhances image quality. It also comes with a larger 25 kW generator, which allows for better imaging on larger patients.
Yeah.
With this C-arm, the surgeons can perform all of the necessary imaging and intraoperative work without leaving the OR suite, which is of enormous benefit to the surgeons and the patient.
Yeah.
This C-arm will provide the vascular surgeons with greater clarity, as it has two 24-inch high-resolution monitors. This is a big improvement for them.
Well, wonderful. Okay, Laura.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Eben.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, motion passes. Item F.
Mr. President, in accordance with district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of replacement computers for WTMF for a total amount not to exceed $31,580.81.
Okay, these replacement. Did you like to
It's
comment?
replacement.
Just replacement.
We purchased these computers in 2012. They're 6 years old. I don't know why a C-arm lasts longer.
Yeah,
but
that's true.
It does.
Yeah. Laura?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Eben.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, that motion passes. Item G.
Mr. President, in accordance with district law policies and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of replacement computers and laptops for WHHS for a total amount not to exceed $98,694.64.
I'm sorry, second.
Okay.
Oh, did we get a second?
Yeah, we did.
Okay.
I was concentrating on replacing computers again, I'm
Yeah.
sorry.
Same deal.
Same deal, yeah.
Okay, Laura?
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Eaton,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, that motion passes. Item H.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the project of painting the exterior of the hospital for a total amount not to exceed $327,750.
Well, I think Ed would have some paint left over from it.
Yeah, and why don't you have any leftover paint? It's been 12 years.
Yeah,
It's time.
yeah. Okay, Laura?
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Eaton,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, that motion passes. Item I.
Aye. Okay, Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the upgrade of the fireworks fire alarm system for a total amount not to exceed $125,000.
Second.
Okay, second. Nancy?
We're installing a new Edwards system in the Morris Hyman Critical Care Pavilion. And before we bring this system online, we'd like to upgrade the interface modules for the other campuses' alarm systems and also upgrade their software so that all of the systems are compatible and we'll have the same system utilized for the entire campus. And this would include the main hospital, the CJR, Central Plant, Washington West.
Very good. Laura?
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Eaton,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, that motion passes. Okay, at this point, we are going to adjourn to a closed session. Thank you. We are going to reconvene the open session and announce that there were no reportable actions taken during the closed session. So at this point in time, we have an action item to consider.
Item J, Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of the Philips Healthcare telemetry system for a total amount not to exceed $504,106.
Second.
Okay, Nancy?
This is a case of end of service and support for these devices and software, and in particular, as of March 2018, for the MicroPack telemetry devices. So we need to replace them.
Okay. Laura?
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Eaton,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, that motion is approved. Are there any other items for tonight? Okay, we're seeing none. This meeting is adjourned. Thanks.